right. Hey guys. We're going to talk today about disorders of sexual functioning, paraphilic disorders, and gender dysphoria. These are actually 3 different chapters in the DSM. So aside from the fact that they all have to do with sex organs, gender roles, and the biology of the hormones involved in sex and gender, they're not related disorders. People with one of these clusters of disorders are not more likely to have either of the others. But I'm lumping them all together because they are all about sex and gender. And the overarching theme is going to really focus on what is kind of normal and how much of what we perceive as normal is like socially constructed as opposed to being objectively normal or abnormal. Okay, so first we're going to talk about sexual dysfunctions. First, starting by defining the context in which they occur. So the stages of sexual arousal and orgasm that can be impaired. And then we'll talk a little bit about what disorders are diagnosed by psychologists and how they're treated. So the stages of human arousal the human sexual response that are affected by these disorders are desire, arousal, and resolution. Desire, arousal, and orgasm. So desire basically just refers to wanting to have sex. It can be used to refer to just like generally being in the mood for sex, including like solo sex, masturbation, or it can refer to a drive or a desire to have a specific kind of sex or to have sex with a specific person. It's a broad term, but desire is kind of considered like the baseline thing necessary in order for the rest of the sexual response cycle to happen. Although that's not true, arousal and orgasm can happen in the absence of desire, and that's actually why the disorders are separate. So arousal just refers to the physiological signs of being aroused, of having a physical sexual response. These are tumescence, so the genitals becoming engorged with blood, and for people with penises, the penis becoming hard and erect. The seeping of fluids through the walls of the vagina or into the urethra. Increased heart rate and blood pressure, so that is part of the increase of blood flow to the genitals, which is part of the sexual response to arousal. And flushing, so that's just a sort of byproduct of increased heart rate and blood pressure. The last stage of the human sexual response cycle that can be disordered according to the DSM is orgasm, which physiologically is just rhythmic muscle contractions in the genitals and reproductive organs, so the uterus and prostate, that people experience as this like extreme release, so a release of the tension that comes from building arousal, or just like extreme pleasure. And what this figure is reflecting is that for many people with penises, orgasm is like a one-time thing, whereas many women are multiply orgasmic. So the orgasm stage of the response cycle is a little bit different for different individuals, but also generally there are gender differences. Okay, so these are the sexual dysfunction diagnoses that DSM-5 recognizes, and basically they're broken down into problems with desire and arousal and problems with orgasm, as well as genitopelvic pain/penetration disorder, which is a disorder that people with vaginas can have when they experience anticipatory anxiety and anticipatory tensing or actual pain in response to penetration. That doesn't have a known medical cause. So medical causes have to be ruled out for that disorder. So the disorders of desire and arousal are male hypoactive sexual desire disorder, which is a lack of interest in or desire for sex, including a lack of desire to engage in solo sex most of the time. So just like no real motivation to have sex with a person, have sex with yourself, or engage in any particular sex act. For women, problems with desire, which is here being referred to as interest, and problems with arousal are kind of lumped in together. So just like male hypoactive sexual desire disorder, this includes a lack of interest in sex, a lack of interest in sexual fantasies, a lack of sort of motivational response to erotic thoughts. But in addition, it can also be diagnosed when a woman has problems with arousal. So even in the presence of desire, like the intention to have sex, wanting to have sex, being in the mood, wanting to have sex with a person with female sexual interest arousal disorder could just have a lack of physical responsiveness to initiation. And what's meant by initiation here is like physical initiation. So a lack of responsiveness to erotic stimuli and erotic sensations. The kind of male equivalent of that is erectile disorder. So this refers to, in the context of desire, so when a man wants to have sex, penetrative sex, but has a hard time doing that because of a persistent inability to get an erection or maintain an erection, or having an erection but it not being as turgid as it usually is or used to be. This is really common as men get older. So it's present in a slight majority of men over 60. It's not a disorder in every case, as we'll talk about on the next slide. So the disorders involving orgasm, for men, premature ejaculation, because erectile disorder doesn't necessarily mean a lack of ability to orgasm. Men can orgasm without having an erection, although in practice, for behavioral reasons or because erectile disorder is involves a lack of physical arousal, many men with erectile disorder aren't able to reach orgasm. But the only male orgasmic disorder that's mentioned in the DSM is premature ejaculation, which is defined as ejaculation that occurs within 1 minute of penetration and before desired. So if ejaculation occurs within 1 minute of penetration, but that was the plan, or it's not a problem for the person involved, or if they're having sex with another person for that person, it's not a disorder. So this one's also pretty common. It affects about 1 in 5 men, but unlike erectile disorder, premature ejaculation tends to affect younger men and it improves with age. For women or people with vaginas and female reproductive anatomy, female orgasmic disorder is defined as just sort of a delay or just kind of an inability to reach orgasm. So basically getting to that plateau stage of arousal where there is a lot of sexual arousal, there's built up tension, but the person is not able to like resolve that tension. They're not able to have the physiological orgasm response. And obviously there's lots of reasons for that. This disorder is only diagnosed when the difficulty orgasming isn't explained by problems in the relationship, how the person feels about whoever she's having sex with, or any other life stressors that are going on. So as we'll talk about in the next slide, well, actually, let's do it right now. Subclinical sexual dysfunctions are pretty common, and by themselves are not disordered. So to be diagnosed with a sexual dysfunction disorder, the symptoms with the problem with arousal, desire, orgasm, or pain has to be experienced in almost every sexual occasion and in almost every context, including partnered sex and solo sex. It has to have been consistently present for a long time. The DSM specifies 6 months, and it has to cause clinically significant distress. So, as I said, like these symptoms are common, and they can be caused by lots of different things. Okay, so yeah, isolated symptoms of sexual dysfunction are pretty common, just like not being in the mood, having a hard time feeling aroused, not really feeling responsive to sexual stimulation, having a hard time coming, like all of that is a very common experience. In studies, like in population-based studies, as many as like 30 to 40% of men and women, some studies actually find that these disorders are, that subclinical symptoms of these disorders are less common in women, but other studies find similar rates. But the takeaway is that a lot of people have these symptoms, but only a small minority of people actually have the disorder, because the disorder means that the symptoms are pervasive, that they are long-lasting, and that they cause a lot of distress. There's also a lot to rule out with these disorders. Depression can cause a loss of interest in sex, and that's not the same thing as hypoactive sexual desire disorder, for example. There is some evidence that sexual dysfunction disorders might actually be a little bit more common in trans people. Although, to my knowledge, there hasn't actually been a study like the one from which these data are coming that actually looks at the prevalence of both symptoms and disorder, so symptoms plus impairment duration, and having ruled out other causes in trans people. But one interesting statistic is that 30% of trans women and 15% of trans men report problems with orgasm, which is a lot more common than the percentage of cis men and women who have disorders affecting orgasm. But the study that these data are coming from didn't actually apply diagnostic criteria for disorders. However, the study did recommend that psychologists and medical professionals do pay more attention to sexual functioning in trans people because it might be an overlooked problem. I also want to emphasize here that there's a lot of individual difference and variation in how people feel about sex and what people want from their sex life. So not everyone experiences a lack of sexual desire as a disorder or a problem. Some people experience it as an identity. So there are people who define their orientation as asexual, but defined by not having an interest in having sex. Okay, so as I mentioned, gender roles play a role in how patients themselves, but also how clinicians perceive problems with sexual response and sexual functioning. So, for example, in our society, men are kind of like expected to be more sexual than women, to have a higher libido, have more desire, be more prone to experiencing arousal, which is supposed to translate into men masturbating more often and wanting to have sex more often. This is a stereotype. It's not necessarily true, but it can influence a man's perception of changes or fluctuations in his libido as a disorder, or it could lead a woman who has a problem with arousal and desire to not recognize it as a problem because she might dismiss it as like, well, women don't want to have sex that much anyway. Also, when it comes to men, male arousal and male orgasm are kind of expected to look a really specific way. Like people have very singular expectations for what being aroused looks like for men. It means having an erection, and what orgasm looks like, it means ejaculating. There's less specific expectations of female arousal and orgasm, and that can cut both ways too. So men might be more distressed by difficulties obtaining an erection, but women who are experiencing a lot of distress because they have trouble orgasming might not realize that it's something that they need to seek treatment for, because society doesn't really talk about the importance of orgasming for women, or even what orgasming looks like for women. To the extent that there are people who believe that women don't orgasm or don't need or want to orgasm, or pathologize arousal in women. So say that, for example, wetness is a medical problem and not a sign of arousal. There's also a myth relevant to the month of November that male orgasm is physically or psychologically unhealthy, and that men should actually be trying to orgasm less and experience less arousal. That's also not true. It's actually kind of the opposite. Men who orgasm more are at less risk for prostate cancer than men who orgasm fewer than 7 times a month. Okay, so when a psychologist is assessing sexual dysfunction, one of the first questions we ask is, have you seen a doctor, a medical doctor? Because very often sexual dysfunctions have a medical cause. They can be caused by, the main 3 culprits are problems with blood flow, problems with sensation, and imbalances in serotonin. So a medical evaluation is needed to assess for and try to rule out vascular diseases like blood pressure problems, and metabolic diseases like diabetes. People with chronic pain, especially chronic back pain and nerve damage, can experience a loss of sensation in their genitals. Medications, especially antihypertensive, so blood pressure medications, and selective serotonin reuptake inhibitors can cause problems with arousal and desire and orgasm. And then the use of drugs and alcohol around sex can also cause some of these problems. So if these things have been ruled out, an important question to ask is like, are they actually having the kind of sex that would lead to arousal and orgasm? There are some sexual knowledge deficits. So one of the roles of a psychologist sometimes is to provide psychoeducation and make sure our patients with problems with their sex lives have all the information they need to have an active and enjoyable adult sex life. When evaluating people with sexual dysfunctions, psychophysiological measures are sometimes taken of arousal. So objective measures of tumescence, so how much blood is in the penis when it's erect, and blood flow to the vagina can actually be like objective measures of arousal. And then in assessing sexual dysfunctions, especially if medical evaluation is kind of ruled out a basic physical cause, it's important to take performance anxiety into account, as well as behavioral factors like masturbation style and avoidance that's driven by anxiety. Okay, so some cognitive factors. Like I said, isolated symptoms of sexual dysfunction are really common. Like sometimes you're just having an off day, you're not in the mood. It can also be caused by things like pain, illness, temporary emotional states, like being really stressed out. It can also be caused by being drunk or being high. So most people who have sex will experience or with other people or with themselves will experience sexual dysfunction symptoms sometimes. But attributions that they make about those symptoms can really make a difference in how they interpret them and how they feel. So internal, stable, and global attributions about isolated sexual dysfunction symptoms like I can't perform, I'm not interested in sex, I'm bad at sex, I don't orgasm, I don't feel desire, can contribute to avoidance of sex or anticipatory anxiety around sex. It can basically create a negative expectation that becomes self-fulfilling because anxiety can cause problems with sexual arousal, desire, and orgasm. Some cognitive distortions that people can sometimes make about isolated sexual dysfunction symptoms can include like catastrophizing, so taking this one isolated event and sort of blowing it out of proportion. Mind reading, so making assumptions about what their partner thinks about their sexual performance. Labeling, so labeling themselves as bad at sex or not interested in sex. Or overgeneralizing, so again, taking an isolated incident and extrapolating from that to like their whole sexual future. So this negative thinking leads to increases in anxiety, especially in future sexual situations that can lead to performance anxiety, which is a major cause of sexual dysfunction symptoms. It can also lead to avoidance of sex, which can kind of worsen sexual dysfunction symptoms too, because it never gives the person the opportunity to prove their negative attributions and cognitive distortions wrong. So that can be kind of a vicious cycle where isolated sexual dysfunction symptoms can turn into a disorder of sexual dysfunction via negative thinking and avoidance. Some behavioral factors that are relevant. So the way that some people masturbate is really different than partnered sex. So when assessing sexual dysfunction disorders, it's always important to ask if people masturbate. Most people wouldn't diagnose a sexual dysfunction disorder if someone has none of the issues when they're masturbating and only has the issues when they're having partnered sex. But sometimes masturbation techniques are just too different from partnered sex. And people can kind of train their bodies and train their sexual response to only happen in certain really specific positions or in response to certain really specific sensations. So sometimes people have basically a conditioned association for arousal that is really tied to their masturbation habits, and that can be important to figure out. When people are anxious about sex, whether because of attributions about isolated performance issues in the past or for whatever reason, self-medication with alcohol and drugs can sometimes be a way to cope with that anxiety. But I would also frame that coping as maladaptive and basically as avoiding the anxiety rather than giving yourself a chance to habituate to the anxiety in the sexual context and prove that the attributions and cognitive distortions aren't true. It also can be self-defeating because some drugs, especially alcohol, can make certain sexual dysfunctions, especially those related to orgasm and arousal, alcohol can make it worse because alcohol reduces sensation. It can also improve others by the same mechanism. So alcohol reduces sensation that can really help with premature ejaculation. But whatever the reason, over time, drinking before sex is a form of avoidance and that worsens anxiety. And if someone ends up in a position where they feel like they can only have sex when they're drunk, that is a cause of distress and dysfunction in their sex life. Okay. So sometimes sexual dysfunctions have medical causes or contributors, and it's important to manage those. So if someone has high blood pressure, that needs to be treated. If someone has nerve damage from back pain, there are like physical therapy techniques and lifestyle changes that can help with that. If someone has loss of sensation and nerve problems from diabetes, they really need to get their diabetes under control. Selective serotonin reuptake inhibitors are a common cause of sexual dysfunction, especially with hypoactive desire and problems with arousal. So sex is really important to people's well-being, and even if an antidepressant is working in every other way, if it's taking away from your sex life, that's reason enough to talk to your doctor and consider a med change. Once underlying medical contributors to the problem are managed, there are drugs that can help improve someone's ability to be aroused, their feeling of desire, and their ability to orgasm. So Viagra, everyone has probably heard of that. It works by increasing blood flow to the genitals. It helps with arousal, erectile, and orgasm disorders. Viagra is mostly used by men, but for women with orgasm and arousal disorders, for women who have sexual desire but aren't able to feel aroused in response to sexual stimulation, even when they're feeling desire, Viagra can work for those women. A problem that Viagra does not really help with, though, is problems with desire. So Viagra is not a great treatment for male hypoactive desire disorder or for women with hypoactive arousal and desire whose main problem is a lack of desire. So because of our stereotypes about women not being as sexual as men, there's a perception that desire problems are more common in women and arousal problems like erectile dysfunction are more common in men. That's not necessarily true, but it is true that women are more likely to perceive their problems as a problem with desire. So there's been this hunt for the female Viagra, quote unquote, that can improve or increase someone's sexual desire, increase their libido, not just their ability to be aroused. So one drug that's on the market for this is Vibanserin, I believe it's pronounced. I've never said that word out loud. It is an SSRI, but it works specifically by increasing dopamine and norepinephrine and actually downregulating serotonin. It's been shown to kind of work in some studies, but in other studies, it really doesn't have an effect. And across studies, it has a lot of side effects that aren't ideal, especially for sex, like being really tired and being nauseous. So it may work for some people, and the mechanism through which it works is lowering serotonin, which decreases desire. So having too much serotonin in your system decreases sexual desire. It decreases libido. That's why SSRIs cause sexual dysfunction. So Vibanserin works by temporarily lowering someone's serotonin, which in theory should increase their desire. But if you're feeling tired and nauseous, then you're not going to want to have sex anyway. So basically Viagra treats arousal problems and Vibanserin was supposed to treat desire problems. Another treatment for desire problems is androgen therapy. So testosterone is the hormone that for both men and women is primarily responsible for mediating desire. But for cis women or any women, androgen therapy is usually pretty undesirable because it has masculinizing effects. It can cause hair growth, voice deepening, things that women don't typically want. Another treatment is medical marijuana. So cannabinoids are produced inside the body as well as the main psychoactive component in marijuana. And they seem to work in the brain by actually enhancing our capability to feel natural rewards. So they make things that are inherently rewarding feel even better. Things like food and socializing, but also sex. So medical marijuana is a really promising treatment for sexual dysfunction disorders. From a psychological perspective, so marriage and family therapists are often the mental health practitioners who treat sexual disorders because they tend to cause the most distress and impairment in the context of a relationship. If relationship problems are really the main driver of the issues with sex, it's not technically a sexual dysfunction disorder because these are problems with sex with the different stages of the sex cycle that don't have any other known cause. But marriage and family therapy is often the context in which couples try to deal with and resolve their issues with sex. Cognitive behavioral therapists and psychologists work with individuals or couples to both manage anxiety around sex, so treat performance anxiety, and help to challenge and restructure some of this negative thinking that people can develop as part of a vicious cycle of having sexual function issues, making negative attributions about them, and having distorted thoughts about them, that leading to increased anxiety, which in turn leads to more problems. Cognitive behavioral therapy can help to interrupt that cycle by targeting the negative attributions and the maladaptive thoughts, as well as the avoidance that can come from anxiety. But something else that psychologists sometimes do with patients is to work with them to be a little bit more flexible in their thinking about sex. So sex isn't always penetration. It doesn't always have to end in orgasm. Sex has like multiple functions and multiple roles in a relationship or multiple purposes for an individual, and it doesn't always have to look a certain way. Okay, so that was sexual dysfunction disorders. Now we're going to talk a little bit about paraphilias, but a big chunk of this is going to focus on kind of a history of what psychologists really even have to say about sex and sexual preferences and how that relates to the history of the field of psychology with same-sex attraction and homosexuality, lesbian, gay, bisexual identification. Okay, but first, the actual disorder that we're going to be talking about is paraphilic disorder. And a necessary ingredient, but not sufficient, for paraphilic disorder is having a paraphilia, which is defined as misplaced sexual arousal or attraction. So this is a quote unquote problem with desire and arousal. And it involves acts or fantasies that focus on anything other than genital stimulation or preparatory fondling with phenotypically normal, physically mature, consenting human partners. So basically anything that's not penis and vagina sex technically is considered a paraphilia, although I think that most psychologists, even if they were trying to diagnose paraphilic disorder, probably wouldn't diagnose something like anal sex or oral sex as paraphilic. There are certain parts of the body that are quote unquote normatively sexualized, and that includes the genitals, the secondary sex characteristics, and the butt. So paraphilias can be manifested in fantasies, urges, or behavior. So again, technically, a paraphilic disorder can be diagnosed in someone who's never actually acted on this sexual interest, but just fantasizes about it. In previous iterations of the DSM, like especially the DSM-3, paraphilias were defined as highly abnormal. So a type of sexual response that most other people wouldn't have, and also as really rigid. So it was only a paraphilia if it was really, really out there and it was something that the person absolutely needed in order to be sexually aroused. That aspect of it has been lost over time. The definition of paraphilia has kind of been watered down to the point that really it's having a sexual interest in anything other than secondary sex characteristics or genitals or people. Okay, so a paraphilic disorder is diagnosed when a paraphilia is causing the person who has it distress and impairment, or when satisfying the paraphilia has caused harm or risk of harm to the person who has it or to another person. Primarily, this is used when a paraphilia is enacted on someone else without their consent, which is rape and sexual assault, as we'll talk about later. But according to the current DSM, sexually assaulting or raping someone, if the way that you do it doesn't involve the genitals or secondary sex characteristics, is considered a symptom of paraphilic disorder. And the DSM does emphasize that a paraphilia itself does not necessarily justify or require clinical intervention. So really it's only a disorder when it causes distress or harm or danger. Okay, so there are as many paraphilias as there are body parts, objects, species, but DSM lists these particular ones because they're the ones that are most commonly seen in clinical settings, which doesn't necessarily mean that they're the most common in the population. It could just be that these are the ones that tend to cause people the most distress. They're also the ones that are most commonly seen in forensic settings. So one of the biggest voices, like lobbies for keeping paraphilic disorders in the DSM, comes from forensic psychologists. So people who make clinical diagnoses in forensic criminal settings. So a lot of these paraphilias involve elements of non-consent, although most people who have these fantasies only fantasize about them, or if they enact them in role play scenarios with consenting partners, which would make them not paraphilic, paraphilic, not paraphilic disorder. But they can be broken down broadly into anomalous activity preference and anomalous target preference. So basically, anomalous activity preference paraphilias are doing something that isn't considered normal sex. So it doesn't involve genital stimulation, anal or vaginal penetration, or the preparation for those things. Anomalous target preference is wanting to have sex or engage in sex acts with something other than, as the DSM puts it, a phenotypically normal adult human. So voyeuristic disorder involves getting sexual arousal from covertly watching other people, so peeping toms. Exhibitionistic disorder involves sexual arousal from exposing yourself to other people, so flashers. Frauderistic disorder is sexual arousal from rubbing up against other people, usually in the fantasy without their consent. Sexual sadism disorder is arousal from causing physical or psychological suffering. Sexual masochism disorder is arousal from being hurt, being bound or tied up, being humiliated, or just being made to suffer in any way. Fetishistic disorder is sexual arousal to a specific object or non-sexualized body part. So this is obviously like a broad range of things, but it can include things like rubber fetishes, foot fetishes. It can encompass like furry fetishes, so fetishes for kind of non-human looking things. It does not encompass bestiality, that's a separate thing. Transvestic disorder is sexual arousal from dressing as a member of the opposite gender. Different from being transgender, because being transgender is about your internal gender experience, not a way that you get sexual gratification. And then lastly, pedophilic disorder, which is sexual attraction to children, usually defined as children ages 13 or younger. Okay, so just want to say right now, I'm going to talk a lot about normalizing paraphilias and accepting them. The exception to that is pedophilia. Basically every fetish, kink, paraphilia can be role played with consenting partners. That is difficult to do with pedophilia. I mean, whether pedophilic desires can ever be acted on is kind of like with role-playing consenting adults or cartoons or whatever is way beyond the scope of this class. So I'm going to be kind of setting pedophilia aside when I talk about other paraphilias. And also later when I talk about how common paraphilias are, every single study that assesses how common paraphilias are does not find that pedophilia is common. At least people in these studies aren't acknowledging it. So when I say that paraphilias are common and should be normalized, I am emphatically not talking about pedophilia. Okay. So how do paraphilias develop? How do people get these sort of unusual patterns of sexual desire and sexual arousal? Where do they come from? The dominant thinking on this is known as conditioned arousal theory or sexual imprinting. And the idea is that paraphilias develop when incidental sexual arousal, so like during puberty, when your body is exposed to a lot of gonadal hormones, you're experiencing kind of a lot of free-floating sexual arousal. When that is incidentally paired with a stimulus in the environment, like a clown, a cartoon on TV, a costume, something like that, that sexual arousal gets paired with that stimulus, and now you have a conditioned association where that stimulus causes sexual arousal in the future. The problem with this is that people with paraphilias, which I'm going to be referring to as kinks on and off throughout this lecture, they tend to report that their interest in their kink goes back to early childhood, so before puberty, usually before age 10. So gonadal maturity, or the time in a person's life when they're experiencing a lot of free-floating sexual arousal, happens usually after age like at least 9 for girls and usually after age 11 for boys. What's happening between ages 6 and 10, which is the age when a lot of people who have paraphilias remember it starting, is what's known as adrenal maturation or adrenarche. And during this period, the adrenal glands are increasing their androgen production. So the body is being exposed to more testosterone and masculinizing hormones. We know that testosterone and androgens have the effect of increasing sexual desire, which is, again, sort of the baseline wanting to have sex, wanting to be with someone or engage in a certain sex act. That is what seems to get imprinted with paraphilias, not so much arousal as desire. At the time in their life when children are starting to develop their lifelong sexual desire patterns, which also includes their sexual orientation, this is the same age when paraphilias start to develop. So it seems like there is an imprinting process where people remember having an early formative experience with their paraphilic object or situation, but it's associated with adrenarche or adrenal maturation, not with puberty and gonadal maturation. Okay, so now that we talked a little bit about paraphilias, we're going to take a quick detour into the history of my field, a very bad part of its history. So until 1973, according to the Diagnostic and Statistical Manual of Mental Disorders, being gay was a mental illness. Just same-sex attraction, that was enough. It didn't have to cause distress or impairment. Just being attracted to a member of your same sex and gender was considered so abnormal, so deviant, so dysfunctional, and so distressing that it was a diagnosis. In 1963, when the field was getting ready to publish DSM-3, 60% of the members of APA, which is the committee that approves diagnoses for the manual, voted to get rid of homosexuality as a mental illness, except they didn't really. They kept it in as something called ego-dystonic homosexuality. So being gay itself it was no longer considered just by default a disorder, but there was still a diagnosis for people who were gay and distressed by it. So this left the door open for psychologists to continue, quote unquote, treating and trying to cure people of their same-sex attraction or their homosexuality. And one of the most common ways that this was practiced was through aversion therapy, which tries to take advantage of classical conditioning techniques to change someone's desire and attraction. So by pairing images of, in the case of homosexuality, the person's preferred gender with pain or nausea or humiliation or some negative experience, they're hoping to basically create a conditioned aversion between sexual arousal towards a member of the same sex and a negative experience. They also then attempted positive pairings where they would essentially kind of bait and switch, have someone like start to masturbate to an image of their preferred gender, and then they would switch it out with an image of their non-preferred gender and hope to kind of train them to have an attraction based on pairing ejaculation, orgasm with that image. Like we talked about with the development of kinks a couple slides ago, this didn't work. And the problem with it could have been that attraction and desire starts earlier, and it doesn't so much have to do with arousal as it has to do with desire. So aversion therapy, basically, it didn't really work. But this is a comedic demonstration of what this therapy actually looked like.
I'm going to show you a picture of Ross, okay? And you're going to remember all the bad things about him, all right? Really focus on his flaws. Do that. Certainly did that while we were going out. Okay. Before we get started, I just want to say for the record that I love Ross. I think he's such a great guy. Okay. Now, close your eyes and imagine that you're with Ross. And imagine that you're kissing him. You're running your hands all over his body. Then you run your hands through his hair. Oh, Christ, it's some kind of racist. I don't know. His hair never bothered me that much. You know, it was always more punchy than it was greasy. Okay. Harder than I thought. Let's try some aversion therapy. Okay? All right. So, yeah, look at the picture. Okay? All right. And, ow! Okay, how do you feel now? Well, like you, Les.
Okay. So what aversion therapy was trying to do was to create a negative association between arousal towards a member of the same gender and negative outcomes. So that's what it looked like. Okay. So other ways that homosexuality was quote unquote treated while it was pathologized by psychologists and also illegal in many countries was through chemical castration. So by encouraging or sometimes forcing people to take drugs that lowered their libido, like SSRIs or androgen blockers, or basically just kind of change their lifestyle, put themselves in a situation where they were not as able to have sex with their preferred people, like being forced into marriage or being forced into a celibate lifestyle like the priesthood. So this is an example of what happened when psychologists pathologized being gay, and the kind of abuse that it opened people up to.
And the Second World War codebreaker Alan Turing has been granted a posthumous royal pardon. Mr. Turing was prosecuted for homosexual activity in 1952, which was illegal at the time. His work at Bletchley Park was instrumental in breaking the German Enigma code, which some say shortened the length of the war. He died in 1954. There's been a long-standing campaign for his name to be cleared. The Prime Minister has welcomed the news, saying Alan Turing played a major role in saving this country. I'm affairs correspondent Danny Shaw.
Brilliant mathematician, computer pioneer, but Alan Turing is best remembered for what he did during World War II at this secret British base at Bletchley Park in Buckinghamshire. He led a team which cracked the Enigma code used by the Nazis to send messages. Historians believe the codebreakers shortened the war by 2 years, saving countless lives. In his personal life, though, Alan Turing suffered immense anguish. He was gay at a time when homosexuality was against the law. In 1952, Dr. Turing was convicted of gross indecency and had to undergo chemical castration. He was no longer allowed to continue his security work for the government. 2 years later, aged 41, Alan Turing died of cyanide poisoning. A verdict of suicide was recorded. It took more than half a century for the state to acknowledge the injustice of Dr. Turing's conviction for homosexuality. Now, following parliamentary pressure, he's been given a posthumous pardon.
The injustice done to him is corrected today by this Parliament. And I think that is the end of that bit of the story about the appalling of gay men.
The pardon was granted by the Queen under the royal prerogative of mercy at the request of the government. He described it as a fitting tribute to an exceptional man. Danny Shaw, BBC News.
Okay, so aversion therapy and chemical castration and like forcing people into marriage of the priesthood, all of those elements kind of came together in quote unquote modern conversion therapy, which is also sometimes called reparative therapy, especially in religious contexts. But basically, this is how homosexuality was treated up until basically the last decade, when all the professional bodies that provide mental health counseling and that conduct psychology research came out and said that it's wrong, it's immoral, and it doesn't work. But what conversion therapy involves is aspects of aversion therapy as well as positive counter conditioning. So trying to pair arousal and orgasm to images of like the right sex. Talk therapy that was focused on identifying like values and aspects of life separate from sexuality and sexual identity and relationships and romance and love that the person could focus on instead. And then using things like HRT strategies to resist sexual urges and redirect sexual energy towards other activities. And all of this was accompanied by encouragement to seek out and just kind of deal with opposite sex relationships or a life of celibacy. So, does it work? In the last just like 5 years, at least 10 ex-gay leaders and therapists have come out as gay and admitted that what they did was harmful and didn't work for them and probably didn't work for the many people that they did it to. This is anecdotal evidence. What we know from research studies on conversion therapy is that it probably doesn't change sexual orientation. Studies have actually reported a pretty high, what they call conversion rate. But what that means really varies a lot from study to study. So for one thing, studies didn't recruit people who were like 100% exclusively gay or same-sex attracted. They recruited people who had any same-sex attraction, including bisexuals, who presumably find it a lot easier to live as straight because they have some opposite sex attraction. They also didn't tend to do long-term follow-ups. So those like ex-gay leaders, in the first couple of years after going through conversion therapy, they presented as straight, said they were straight, maybe thought they were straight. It didn't last. So the research on conversion therapy didn't provide any long-term follow-up. They also didn't even really measure changes in sexual orientation. They mostly focused on changes in sexual behavior. So it's one thing to stop having sex with the people that you're attracted to, but it's another thing to stop being attracted to those people. And conversion therapy, there's really no evidence that it did that at all. It didn't change desire, arousal, fantasies, wishes, or love. And then again, definitions of success varied across studies, like whether it measured sexual behavior or fantasies or whatever, but none of these studies actually measured increased sexual and romantic attraction to the opposite sex. They just mostly focused on like dampening same-sex attraction and interests. In addition to not working to change sexuality, it's also harmful. So for people who are seeking it out, even like people who are gay and don't want to be, it doesn't change their sexual orientation, and it reinforces their negative feelings about their sexuality that brought them to conversion therapy in the first place. And as we'll talk about in the next couple slides, internalized homophobia, so self-loathing, negative feelings about your own sexuality, contributes to psychopathology and physical health outcomes. Also, being in the closet is a huge stressor, and it's a big emotional and cognitive load for people. So forcing people into the closet and encouraging them to stay there is harmful, not helpful. So the consensus on conversion therapy now is that for people who are religious or from cultural backgrounds who personally don't accept their own same-sex attraction and don't want to identify as lesbian, gay, or bisexual, that self-acceptance will take time and work, which a psychologist is trained and prepared to provide. Conversion therapy doesn't change orientation. It reinforces negative feelings about the self, and it wastes the time that people need to be putting towards acceptance. From an ethical standpoint, like as a psychologist, we're not supposed to practice outside of the scope of our training, and we're not trained in how to change people's sexuality. We don't know how. So any attempt to do that would be practicing outside of the scope of my training, and it would be against my professional code of conduct. Okay, so this is a first-person perspective on what it's like to go through conversion therapy for same-sex attraction.
I'm in Piedmont Park, the home base for Atlanta Pride festivities, to meet with Peter Nunn. Peter is a hairstylist, husband, dog parent, and a conversion therapy survivor.
I firmly believed that God didn't want me to be gay and that he was all powerful and he could fix it.
At the age of 15, unbeknownst to him, Peter was sent to a therapy center in Iowa by his parents.
My dad took me on a trip and he didn't tell me where we were going. And then I remember very well, we were in a layover in St. Louis, and he told me that he was taking me to a therapy center in Iowa to fix whatever weird sexual shit was going on with me. Then he told me that if that didn't work, that he was going to send me to a military school to try to make me a man.
Conversion or reparative therapy is the practice of trying to change an individual's sexual orientation using psychological or spiritual interventions. Conversion therapy has been around since the 19th century, utilizing methods ranging from invasive questioning to electroshock. These practices have since been opposed by the American Medical Association, the American Psychiatric Association, the Pan American Health Organization, and more.
What were some of the sort of lines of questioning that you remember particularly well? A lot of stuff about if I had ever been molested, if I had masturbated, one of the therapists asking the size of my penis. But then it went back to, you have to fight this, you have to be fixed.
What was that 5-year period like when you got back?
I would spend every Sunday in church praying and crying, every night in bed praying and crying for these desires to go away. I was probably at an all-time low.
After years of battling depression and trying to pray the gay away, it was Atlanta Pride that inspired Peter to finally commit to loving himself.
During the parade, the P-Flag group marched by, and they were holding signs that said, I love my lesbian daughter, or I love my gay son. And I wanted that so much. And not just from family or from friends, but I wanted to love myself that way. Peter.
Okay. So that's one survivor's take on what it's like to go through conversion therapy. As you can see, like when he started, he probably would have said that he really wanted to do it. He didn't want to be gay, and he had lots of external forces that were pressuring him to believe that it would work or to really try hard to make it work, and it still didn't work. So most people, well, I don't want to say most, but a lot of people who went through conversion therapy really, 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 really wanted it to work, and it still did, which should tell you that it just doesn't work. Okay. So when we're thinking about getting back to paraphilias for a second, because again, this is a sexual response pattern that the DSM pathologizes, much in the way that it used to pathologize homosexuality and same-sex attraction, we have to ask the question of how do we decide what's normal? And as we talked about way back in the beginning of this class, one way that psychologists decide what's normal and what's pathological is by looking at the 4 Ds. So deviance, is it unusual? Distress, does it bother the person who's experiencing the symptoms? Is it dangerous to the person or to other people? And does it cause dysfunction? Does it interfere with friendships, romantic relationships, or occupational functioning? So we can ask these questions about homosexuality and same-sex attraction kind of as a precursor to asking them about paraphilias, because we've kind of asked and answered these questions already about same-sex attraction. So way back in 1943, a psychologist, or I actually don't know if it was a psychologist, but he studied sex. A sex researcher named Alfred Kinsey surveyed men and women and found that 37% of men and 13% of women in his sample, which by the way was in like Indiana, so, you know, not like a big coastal city, reported having had same-sex experiences. Now, this isn't necessarily same-sex attraction or a lesbian or gay identity, but same-sex experiences. And this research was surprising to Alfred Kinsey. He really didn't expect that many people to have had same-sex experiences. So it changed his way of thinking, it opened his mind, and it led him to develop the Kinsey scale, which is a 0 to 6 scale that people can rate their own attraction patterns on. Where a rating of 0 means that you're 100% only attracted to members of the opposite sex. A rating of 6 means that you're 100% gay, you're only attracted to members of your same sex. And any rating in between means that you're somewhere on the spectrum in between that. A rating of 1 or 2 means that you have some same-sex attraction, but mostly straight attraction. Rating of 4 or 5 means that you're mostly gay, but you sometimes experience attraction to members of the opposite sex. And a rating of 3 means that you're really 50-50. You experience attraction to both men and women. If you don't experience sexual attraction at all, and you identify with that and don't want to fix it, that's an asexual identity. So even back in the 40s, same-sex behavior wasn't that unusual, and psychologists or sexologists back then understood both that people were gay and also that people were bisexual. Nowadays, and this is data from, I think, 2017, people are increasingly recognizing that many of us aren't completely straight. So in a survey of a representative population-based survey in the United States of all adults ages 18 and over, in the full sample, about 78% were totally straight. But of younger people, so people in this figure ages 18 to 30, about 65% of them were straight, which left a large number reporting some degree of same-sex attraction. So this is the same data, but broken down a little bit more by age. So what we can see is that of 18 to 34-year-olds, so the demographic that most of you guys are in, only a little bit over half actually said that they were completely straight, and about like 35 to 40% said that they were either bisexual or completely homosexual. So what this is showing is that, is that same-sex attraction isn't it's not deviant. If something is not deviant or unusual if 35% of people are endorsing it. And even though it's more common to endorse being bisexual in younger people, the prevalence of being completely same-sex attracted is actually pretty much the same, if not higher, in older people. So some degree of same-sex attraction is really normal and common. It's not deviant. Same-sex attraction is also not distressing. So the rationale for even including it in the DSM back in the day was that in mid-century America, gay people did have poor psychological and health outcomes like depression, anxiety, substance use, and suicide. All of these things were way more common in self-professed, same-sex attracted, gay and lesbian identified people. And there were theories about why being gay was pathological, that it was caused by overprotective parenting, that it was caused by sexual abuse, deviant personality traits, problems with sexual and emotional development. None of that is true. And today, in a society that is a lot more accepting of same-sex attraction, if not completely accepting, gay people are only at elevated risk for negative physical and mental health outcomes if they experience things like being rejected by their family, being discriminated against or stigmatized, if they're in the closet, or if they have a lot of internalized homophobia. And all of these things are examples of a phenomenon called minority stress, which is the experience of social stress, like chronic, constant, cognitive and emotional load related to stigma and prejudice against a minority group that you're part of. Gay people are obviously not the only minority group that experiences minority stress. Racial and ethnic minorities in the United States experience it too. So even though it's associated with distress via minority stress, there's nothing inherently distressing about same-sex attraction. All the distress comes from social stigmatization and being in the minority. It's also not dangerous to be gay. So people in the past, when being gay was still pathologized by the DSM, argued that it's dangerous, that gay people had a shorter life expectancy than straight people. And while it is true that there are specific dangers associated with having a gay or lesbian identity, still in the United States, people who are gay are still more likely to experience hate crimes. This was done in 2012. Hate crimes against Jewish people and Black people have only increased since then, but anti-gay hate crimes have pretty much stayed the same. In the 80s, the life expectancy for gay men was dramatically reduced by the AIDS crisis. But there's nothing inherent about being gay that made people more vulnerable to HIV and AIDS. And now, of course, the AIDS crisis it affects people regardless of sexual orientation. What made AIDS particularly dangerous to gay men was really government inaction. Because this was initially only affecting gay men and IV drug users, Ronald Reagan's government really didn't do anything to step in to stop it and study it, try to treat it until it was too late for a lot of people. But if you contrast these dangers from living in a homophobic society with the inherent dangers of symptoms of some psychopathology, like eating disorders, substance use, or lack of sleep, the difference is clear. There's nothing inherently dangerous about being gay. The only dangers come from the outside. Being gay is also not dysfunctional. So dysfunction is defined as impaired functioning in family, social, and work settings. And again, there's nothing dysfunctional about being same-sex attracted unless you live in a society that makes that life harder. So society is responsible for addressing causes of dysfunction by ensuring that gay people have a right to marriage and divorce protections, that they have legal protections for employment and housing, that there's anti-discrimination legislation in place to punish hate crimes more harshly, and as a broader society, that we move towards complete acceptance of lesbian, gay, and bisexual people and start censoring the families that reject them. So for a first-person perspective on this is a quote from the sex advice columnist Dan Savage about coming out when he did in the 80s. So, and he was talking about coming out to his mom. And he said, one of the great pains for my mom when I came out was that I wasn't going to be a parent. You know, really when I came out in 1980, what you were saying when you opened your mouth and said I'm gay to mom and dad was, in addition to I'm going to boys now, was that I'll never be a parent, I'll never be married. What I did when I was coming out in 1980 was I said I'm walking away from these things, these possibilities, family and marriage, because I can't fake it. I can't lie to a woman all my life, and I wanted to live with integrity. And then in the course of my life, as more gay people came out, as the gay and lesbian civil rights movement advanced, more became possible, and then marriage and family re-entered the picture. And that's him with his husband and son. So what this is really illustrating is that being gay didn't change, society changed. And that societal change, the greater acceptance of LGBT people, was what made it less dysfunctional to be a member of that group. Okay, so being gay is definitely not a disorder. So why are we talking about it in the context of psychopathology and sexual disorders? So when it comes to being gay, we know it's not deviant because more than a third of people are gay or bi. We know it's not inherently distressing, inherently dangerous, or inherently dysfunctional in a society where lesbian, gay, and bisexual people have equal rights. But I'm going to make the case that all of these things are also true of paraphilias, again, other than pedophilia, which is a complete exception. Not going to talk about it. Although in the notes section for this slide, there's some further readings and resources about research on pedophilia. Also, before I get into normalizing paraphilias, I do want to make a distinction between the two ways that you can get diagnosed with paraphilia. So one way is, even if the paraphilia doesn't cause distress to the person, if a paraphilic behavior is directed towards non-consenting people, then that's enough to diagnose someone with a paraphilic disorder. So basically, if someone is going around flashing people without their consent, sorry, my cat's really sad that she can't go outside. If someone is going around flashing people without their consent, that is sexual assault, but it's also diagnosable as a paraphilia. But the thing is that so paraphilias are just sex, and people engage in non-consensual sex acts for lots of reasons, including problems with impulse control, so not being able to stop themselves, not really understanding consent, either because of an intellectual limitation or willful ignorance. Sometimes it's because they're just antisocial and they want to take what they can get without really caring about how it makes other people feel. But often non-consensual sex is not about sex at all. It's about dominance and power. It's about intimidating and hurting someone else for the sake of hurting them or to gain control over them. It's really not about sexual gratification for the perpetrator. And basically my feeling on this is that being a rapist or sexually assaulting someone is not considered a psychological disorder. So it shouldn't matter whether the non-consensual sex act is normophilic, which is a sex act that involves genitals and penetration, or paraphilic, which would be something like flashing someone, rubbing up against someone, hurting someone without their consent, or engaging in any sex act with a child because children are too young to consent. So basically what I'm saying here is that I don't think that this is a good reason to diagnose someone with paraphilic disorder. Because as I'll talk about, paraphilias are really common, and people with paraphilias are not more likely to be rapists than anyone else. So the more common way for paraphilic disorders to be diagnosed, at least by clinical psychologists like me and not by forensic psychologists, is that the paraphilia causes distress, shame, embarrassment, or relationship problems for the person who has it. And this is just an example of that. This is actually a quote from a letter to Dan Savage, the advice columnist. I didn't really curate this. I just basically grabbed the first one I could find. But someone writing about their partner says, we've known each other for years, but have only been dating for 4 months, and the sex is great. We talk about what turns us on, and I feel like we share a good amount. However, she's made a few comments recently saying she doesn't want to scare me away with her sexual fetishes and interests. I don't think she realizes that it makes me a little nervous. So this is an example of someone, the partner of the letter writer, who has a lot of internalized shame and embarrassment and fear of rejection tied to her paraphilias. And it's causing some problems in the relationship because she's afraid to disclose, and that is making her partner worried. So this is the more common way for someone to actually seek treatment for a paraphilia. They have this pattern of sexual arousal and desire that they don't want to have. So they come to a psychologist to try to have it taken away. This is actually, the textbook comes with slides, and I don't usually use them, but this is one of the slides that comes with the textbook. This is how the textbook claims modern psychologists treat paraphilic disorders. And to me, it looks just like conversion therapy. So there's covert sensitization, which is basically aversive counter conditioning, imagining aversive consequences. We're a little bit more civilized now, so we don't actually hurt people. We just have them imagine negative situations and try to pair that with the deviant behavior. They use pedophilia in this slide, and I'm not saying I disagree that pedophilia is deviant, but these same treatments are used for people who are offending pedophiles and also for people who have a spanking fetish who want to get rid of it. Orgasmic reconditioning is masturbation to appropriate stimuli, so the same thing as encouraging gay men to try to masturbate to pictures of women, and also prescribing people with paraphilias drug therapies to lower their sex drive, similar to the chemical castration that was perpetrated against mostly gay men in countries where being gay was illegal, like England and the United States. Okay, so that's, according to your textbook, how paraphilias are treated today, right now in the United States, even though we know that aversive therapy to change someone's sexual orientation doesn't work. So I'm going to ask on the discussion board, I'm going to ask you guys for your thoughts on this. I'm just going to give you my thoughts on whether paraphilias, again, excluding pedophilia, are deviant, dangerous, distressing, and dysfunctional. And I will say that according to the research evidence we have, pedophilia is really rare. Less than 1% of people admit to being pedophiles, but there might be more people than that who know better than to admit to it. Okay, so are paraphilias deviant? I'm going to just switch to calling it kink now because that's the terminology that people with kinks prefer. Paraphilia is stigmatizing and pathologizing, and I don't agree with that. So kink is really common, and it exists on a spectrum where most people, and again, this is research-based, most people who respond to research studies report that they have both kinky and quote-unquote normophilic fantasies. So normophilic fantasies are fantasies about penetrative sex, blowjobs, kissing, romantic like scenarios with a member of that person's preferred sex. So whether they're gay or straight. Another word for normophilic that people use in the context of kink is vanilla. So I might sometimes slip into that. But what I'm saying is that most people have both. And in fact, when we use the DSM's own definition of a paraphilia, which is an interest or arousal pattern that's stronger than normophilic vanilla arousal patterns, as many as 50 to 60% of people actually meet criteria for a paraphilia because they have a kinky sexual fantasy that they say is more intense than any of their normophilic fantasies. And although paraphilias are thought to be more common in men because most sex offenders are men, and that's the primary setting in which paraphilias are diagnosed, 50% of non-offending regular people with paraphilias are women. Another source of data on this comes from the company Pornhub, which releases yearly aggregated data on how people use their website. So this is from 2019. These are the categories of porn that people searched for the most. And what's circled here are all of the kinky, paraphilic searches that are extremely popular. Actually, there's more paraphilic searches than there are normophilic searches for things like amateur porn or whatever. There are searches for like aliens, so that's not a human. There's searches for mature. So in the DSM, we rightly pathologize sexual attraction to minors, but sexual attraction to older people based on fetishization of their age, because age is not a secondary sex characteristic, it's not breasts or genitals, that's considered a paraphilia. So paraphilias are super common. Kink is really common. Kink is also not inherently dysfunctional or distressing. So similar to minority stress in LGBTQ people, surveys of people who are kinky and who practice kink, people who consider their sexual orientation to be kinky, consistently find that on average, people with kinks don't function any differently than people with more normophilic sexual interests. They also aren't more likely to have comorbid disorders like anxiety disorders, mood disorders, PTSD or a history of trauma, personality disorders. On all of these metrics of distress, impairment, and dysfunction, they don't differ from the general population. In fact, well, for one thing, 50 Shades of Grey was like one of the most popular books and movies ever. And so that should show just how normal kinky interests are, because millions of people read this book about BDSM and like presumably enjoyed it. But in the book, 50 Shades of Grey, and in the movie, the protagonist's interest in BDSM was framed as a product of his having been abused as a child. And there is this misconception that people who are into BDSM, which is an acronym that stands for bondage, dominance, sadism, and masochism, and kind of encompasses the paraphilias of masochistic and sadistic disorder. There's a misconception that people with BDSM are just doing it because they're like working out unresolved childhood trauma. But research, again, has consistently showed that people who are into BDSM are not more likely than the general population to have experienced any kind of child abuse. In open-ended surveys of kink-oriented participants, so these are people who, while they might also identify as gay, straight, asexual, well, probably not asexual, but gay, straight, lesbian, bisexual, they also identify as kinky, so it's part of their self-identity. While these practitioners do describe experiencing things like stigma, stress, stress from concealing their interests and orientation, the most dominant theme when they talk about their kink and their orientation is positive emotion, growth and exploration, and being part of a community. So again, this interest isn't leading to dysfunction in their lives so much as it's leading to positive things in their lives. And then lastly, kink isn't dangerous, with a caveat that some kinks do involve potential dangers. So like BDSM, people who sexualize pain are putting themselves at risk. And practitioners who are working with patients, whether those practitioners are psychologists or medical doctors, should be able to have an open, comfortable conversation with their patients about safe sex practices, whether they're talking about condom use or whether they're talking about making sure that people are practicing kink safely. People who are into BDSM in research studies like the one I showed on the previous slide actually say that they personally would feel safer. They would feel like they were able to practice their kink more safely if they could have an open conversation with their healthcare providers about it. So that being said, some people have kinks that are too dangerous to actually enact. So people should never do breath play or autoerotic asphyxiation. There have been some really famous deaths from that. Other kinks involve negotiating risks and benefits, and those are assessments that we let consenting adults make in lots of other domains, like going skydiving, drinking alcohol, eating undercooked meat. Like adults can choose to put themselves in a little bit of danger, and we don't consider that psychopathology. And then, of course, many kinks are actually safer than penetrative sex because there's no risk of pregnancy or STDs. Okay, so we talked about how minority stress in modern America is kind of the main thing that contributes to negative physical and mental health outcomes for gay, lesbian, and bisexual people. When we talk about treatment for paraphilic disorders, if I had a patient who was coming to me really upset about their kink or their paraphilia, the treatment that I would recommend, and of course I would like describe it to them and I would give them the opportunity to make an informed choice to give consent to the treatment that I would provide. But the only treatment I would really be willing to provide is kink acceptance and sex positivity. So sex positivity is defined as being comfortable with one's own sexual identity and with the sexual behaviors of other people. And the goal is to promote healthy, smart, safe, and consensual sex for everyone. And kink positivity and kink acceptance is part of that. So in my opinion, like the defunct diagnosis of ego-dystonic homosexuality, having a kink and being distressed by it isn't a problem with the kink or the desire pattern. It's a problem with how the person understands the desire problem, and in many cases, it's a problem with how society and the people in that person's life understand the desire pattern. Okay, so thinking about inclusivity when it comes to sexual behavior, just to add a couple more terms, like to define some terminology. When we talk about same-sex attraction, we're actually talking about two separate dimensions that intersect with each other. So there's romantic attraction, which is the desire for closeness and emotional intimacy, who we fall in love with, who we imagine a future with, who we have like a romantic crush on. And then sexual attraction, which is the people who are the objects of our sexual desire. These things are usually in alignment. So most people are sexually and romantically attracted to the same types of people, but for some people they're not. So some people who are asexual identify as having romantic desire and vice versa. Some people who are sexual say that they don't really feel romantic attraction. Many people who are bisexual, so experience sexual attraction to members of any sex, might have more of a romantic preference for either the same sex or the opposite sex, so being bisexual, but heteroromantic or homoromantic. The writer and sex advocate, kink educator Gillian Keenan argues that sexual attraction, so who you desire and who you experience arousal towards or with, is more than just the person that you want to have sex with. It's also how you want to have sex. And so she considers kink to be sort of a third factor in someone's sexual orientation, not just who they love, not just who they have sex with, but also how they have the sex that they have. So she proposes these kind of three spectrums, although I will say that these spectrums are oversimplified because they imply like binary genders. We'll show some slightly more inclusive and complicated spectrums in the transgender identity part of this lecture. But Gillian Keenan argues that everyone is on somewhere on each of these three spectrums, from how attracted you are to, we could say, members of the same sex to members of the opposite sex, how romantically attracted you are, who you can fall in love with, members of the same sex or the opposite sex, and also how you want to have sex. So how much your sexual desires are normophilic, focused on genitals and secondary sex characteristics, versus how much they're paraphilic or kinky, so how much they're focused on objects or scenarios or situations that most people don't sexualize. Okay. Whew. So moving on to gender dysphoric disorder. We're going to talk about what gender dysphoria is, as well as what the difference is between gender dysphoria and gender nonconformity. And then, sort of like we took a detour into sexuality, we're going to take a little detour into gender roles and intersex conditions before we talk about treatment for gender dysphoria, which is transition. Okay. So in this part of the lecture, I'm just going to go over some terminology. So when I talk about sex in this context, I'm referring to the biological basis of reproduction and whether someone is biologically male or female. When I talk about gender, I'm going to talk about socially constructed characteristics or roles in our society of two genders, men and women. When I talk about people being transgender, that refers to anyone whose gender identity doesn't match the biological sex that they were assigned at birth and the gender roles that were imposed on them based on that sex assignment. Someone who is cisgender is anyone whose gender identity matches the biological sex that they were assigned at birth. Natal gender refers to the gender associated with the sex assigned at birth. So if when you were born, the doctor said it's a girl, your natal gender is female. You're also AFAB, or assigned female at birth. If when you were born, your natal gender was male, you're AMAB, or assigned male at birth. I'm not even sure I use this terminology later, but just for future reference, MTF stands for male to female transition, so someone who's a trans woman, and FTM is female to male transition, so someone who is a trans man, or just a woman or a man. And then gender non-binary is someone who identifies with neither female gender nor male gender. They might identify with like an ambiguous or androgynous gender in the middle, or they might not identify with gender at all. Okay, this is an infographic that also helps to illustrate some of the differences between sex and gender. So in the middle, we have some of the biological determinants of biological sex: chromosomes, reproductive organs, gonads, and genitals, and the hormones that we're exposed to. But then on the other hand, we have the culturally determined aspects of gender. So roles and responsibilities, perceived attributes like emotions and personality traits, and entitlements, benefits, privileges. This figure kind of only talks about male privilege, but there are benefits to female gender identity too. I don't think I really get into it in this lecture, but one example of a privilege that women have in a sexist society is that when women are allowed to be more emotional, it also allows women to seek help more easily and to get more social support from our friends. Whereas because men are, a male gender role in our society is that men are supposed to somehow be less emotional or less emotionally expressive, that hurts men by making it harder for them to seek out social support, physical affection, reassurance, and comfort from their friends, especially their male friends. Okay, so what is gender dysphoria or gender dysphoric disorder? Gender dysphoria is a marked incongruence between one's experienced or expressed gender and one's assigned gender. So there are different criteria for this for prepubertal children and for adolescents and adults. But in both cases, the gender dysphoria has to cause distress and impairment for it to be a disorder. Although almost by definition, anyone who's experiencing this incongruence is probably experiencing some level of distress, because this type of incongruence between how you feel and how you see yourself and how other people see you is really distressing to humans. Okay, so the criteria for gender dysphoria in young children is when a child expresses a strong desire to be the other gender or insists that they are the other gender. So when someone who's assigned female at birth is saying that actually I'm a boy from a young age. When that person has a really strong preference for, in this case, an assigned female having a really strong preference for boys' clothing, or being really, really resistant to wearing girls' clothes, so refusing to wear dresses or getting really upset when their parents make them wear dresses. That same person having a very strong preference for cross-gender roles in play. So like when they're playing pretend, even though they are assigned female at birth, they want to role play as like the dad when they're playing house. A strong preference for the toys, games, or activities stereotypically used by the other gender. So that again, in this example of an assigned female, when a child is expressing their gender dysphoria, they might do that by sort of like rejecting girls' toys, rejecting things that are pink, like focusing on things like video games or sports because those are stereotypically associated with boys. Similarly, having a strong preference for playmates of the other gender because it's developmentally pretty typical for prepubertal children to have a preference for playmates of the same gender. So when someone has gender dysphoria, because their internal gender is not the same as their external gender, their preference is for playmates of the supposedly opposite gender. Rejecting toys and styles of play that are stereotypically associated with their assigned gender. And then, so all of these things are kind of behavioral and all of them have a lot to do with gender roles and gender norms. But children who are trans, children who are gender dysphoric can also express a really strong dislike of their sexual anatomy or a strong desire to have the primary or secondary sexual characteristics of the opposite sex. So this would be like an elementary school aged boy assigned male at birth who identifies as a girl, being really bothered and distressed by having a penis because as a girl, they should not have a penis, they should have a vagina. And so some children do express that kind of distress about their genitals or their secondary sex characteristics. But anatomical distress is actually less common in children than some of this like basically strong gender nonconformity. Moving over to adolescents and adults though. So once someone has started puberty or has gone through puberty, gender nonconforming behavior is not enough to be diagnosed as gender dysphoric. You have to have this marked incongruence between experienced gender and your own sort of physical body. So basically this is the sense of like being a woman trapped in a man's body. Like incongruence between the fact that you're a woman and the fact that you also have a masculinized body and male genitals. A strong desire to be rid of one's primary or secondary sex characteristics. So not only feeling like it's wrong that you have a hairy body and male genitals, but really wanting to get rid of that. Or also having a really strong desire to have secondary sex characteristics associated with women, like smooth skin, protruding hips, and breasts. Strong desire to be the other gender, or a strong desire to be a different gender than what you were assigned at birth. That incorporates people who are gender non-binary. A strong desire to be treated as the other gender or as an alternative gender. So being a woman, even if your body looks like a man, it feels really uncomfortable to be addressed as sir or to have people use he, him pronouns for you. Or a strong conviction that you have the typical feelings and experiences of the gender that you identify with rather than the gender that you were assigned at birth. So feeling like I react to things as a woman, I want to have relationships with other people as a woman. When I fall in love, I want to be loved as a woman, even though I'm in a man's body. That's what gender dysphoria looks like for an adult or an adolescent. So a first-person perspective on this comes from the YouTuber Natalie Wynn. This is actually, I think this is from a deleted video, but the transcript is still online, called Dysphoria, which is a dialogue between a cis person and a trans person. The cis person asks, what does it even mean to feel like a man? And the trans person responds, well, don't you feel like a woman? This person says, no, I feel like myself, which is kind of the experience that Wynn is trying to capture. It's not so much that she like wants to be a stereotypical woman, wants to just have long hair and wear dresses. It's more than just looking like a woman or inhabiting gender roles. She just is a woman. And she also, in the same video, talks about sort of disgust at her secondary male characteristics, having body hair, feeling like it's not even human hair, like it's disgusting. That's experiencing a really strong aversion to the secondary sex characteristics associated with the gender that you were assigned at birth. And then this video also, I believe this clip is the performer Laura Jane Grace talking about her experiences with gender dysphoria, but she also interviews other trans people in this video.
I explain it as saying a feeling of misalignment between the way you feel and the way other people perceive you.
feeling like that your gender does not line up with your assigned gender at birth. Well, when you're too young to know what it is, it turns into shame. Just simply being like, I mean, being 5 years old and being like, I want to be a girl. Like I feel like I should have been a girl. And then knowing that if you were to express those feelings to someone else, they wouldn't be accepted or understood, and that you'd be shamed for it.
The earliest age that I knew I was struggling with my gender was 4, and I thought I could bring it up with my parents at all, or they'd disown me.
Well, I always felt really pressured by them to be very like normal, like very assimilated. So like all of these things that I knew I wanted for myself, I didn't really feel like I could have on. I grew up in a really strict religious household. That I just assumed that my gender was taken to a therapist in the hospital for that way. That point was worse than puberty.
Well, and I think puberty makes you super hyper aware of everything because your hormones are running wild and your body is starting to change. So all the things that you're already aware about yourself become that much more exaggerated.
I definitely shut down during puberty. I was just like, I became really awkward. I remember not being able to take a shower. I hated touching my body. I felt like my body wasn't mine, it was somebody else's. Things happen to your body. And, then I realized, oh my God, I'm actually really a girl. That was devastating for me.
Okay, so those were all examples of what it's like to experience gender dysphoria, both as a child, which often is more of an experience of like, oh, I want to be a boy, I should be a boy, it feels more right to do boy things, I want to be seen as a boy. As puberty approaches, people tend to experience an acceleration of dysphoria. It gets more intense, and the dysphoria it begins to start focusing on the physical body. So emerging secondary sexual characteristics like breasts or body hair, or focus more on primary sexual characteristics like genitals. As we'll talk about later, puberty, so the early stages of puberty especially, is a developmental time period when the difference between a child who's gender nonconforming but not trans and a child adolescent who is transgender becomes really apparent, because gender dysphoria tends to really ramp up and increase at puberty, or in a child who was very gender nonconforming as a child but may not have actually been experiencing true gender dysphoria. Puberty is a time when that becomes apparent too, as we'll talk about later.
94.
Okay, so this slide asks how common is gender dysphoria, and we actually don't really know, mostly because the language and awareness about being transgender, about the possibility that someone's internal experience of gender didn't align with their external body, or even that there is such a thing as having an internal experience of gender, that concept hasn't always been understood. But using our modern 21st century understanding of gender dysphoria and trans identity, we think that the prevalence of being trans, having gender dysphoria, is between 0.5 and 1% of the population. But they're a cohort effect. So it seems like in the past, according to the evidence that was available then, which is different than the way that we measure gender identity now. But so that's one source of this cohort effect, where it seems like being transgender was a lot rarer back in the day, back before the 70s. So before the 70s, rather than kind of directly asking people, are you trans? Do you have gender dysphoria? The prevalence of gender dysphoria and trans identity was measured as things like how many people were applying to have their name changed from a feminine name to a masculine name, how many people were being prescribed hormone therapy in countries that have a national health service where those records are centralized, and how many people in a country had, instead of male or female, an X on their passport, because historically in Europe, it wasn't possible, in most European countries, it wasn't possible to change your gender identifier on your passport, but you could remove it altogether. So based on that kind of data, the prevalence of lifetime gender dysphoria and trans identity was really low. I imagine it was higher than that because being trans was so stigmatized and so poorly understood. Not very many people had the ability or the desire to take on the risks and potentially life-threatening consequences of being openly trans. So I'm 100% sure that those prevalence estimates were too low. there is some evidence that the prevalence of transgender identity is still increasing, and that there are continued cohort effects where, like, my generation, millennials, and the next generation, Gen Z, the prevalence of trans identities, just like the prevalence of bisexual and same-sex attracted in general identities, is higher. This cohort effect is most likely due to increased visibility, and people actually point to Caitlyn Jenner, who transitioned really publicly in 2015, as helping to contribute to kind of a tipping point in our society's awareness of the reality that people are trans. She also, because she's someone with a lot of privilege and a lot of money, she was able to kind of transition, quote unquote, successfully in the public eye. Like, she really showed that it's possible for someone, even as an adult, to really make their physical appearance match their internal gender experience in a way that, like, society recognizes. So from the best evidence we have, which mostly comes from treatment-seeking people who are getting gender-confirming treatment, the prevalence of gender dysphoria is pretty much the same in people who are assigned male at birth and people who were assigned female at birth. The T part of the LGBT population is about 5%, but of course that's not exclusive, because being trans is a gender identity, but people who are trans also have a sexual orientation. So plenty of trans people are lesbian, gay, or bisexual too. Okay, so here I think it's really important to emphasize the distinction between gender dysphoria and gender nonconformity. So gender nonconformity is just a person who has behaviors or preferences that don't really line up with the stereotypes associated with their gender. Dysphoria is distress and discomfort caused by being in the wrong body, having the wrong sexual characteristics, having the wrong physical body that doesn't match your internal gender. There are plenty of cis women who present really masculine, who are very gender nonconforming. This can be cis women who predominantly wear men's clothes, or who are in male-dominated fields, or who just aren't like stereotypes about women as being like into clothes or emotions or whatever. That is gender nonconformity. It's totally distinct from gender dysphoria. But because it's difficult for children to articulate dysphoria, and because they might not actually be feeling dysphoria, because prepubertal children aren't paying that much attention to their physical bodies, and they aren't necessarily as aware of what genitals they should have as the gender that they belong to internally, it's less likely that they'll express dysphoria about their anatomy. So when it comes to prepubertal kids, there is somewhat of a conflation of gender nonconforming behavior and gender dysphoria. So where do the gender norms and the gender roles that help define gender nonconforming behavior and that help to, that give trans people a lot of dysphoria when they experience them in their day-to-day lives, where do those come from? So gender norms are defined as societal expectations of how dress, behavior, social interactions, and roles in society correspond to gender. And in our society, we see it as two genders, male and female. Gender roles are, to a large extent, culturally specific. So something as trivial as the association of pink with girls and blue with boys is pretty modern. In the 18th century, boys actually wore pink and girls wore blue, because blue was associated with the Virgin Mary and pink was a youthful form of red. Gender roles are kind of imposed on kids from birth, because we assign children a gender at birth based on their sex. From very early on, that influences the way that they're seen, the way that they're treated by adults and by their peers, and the types of experiences that they have at an age where adults are kind of mediating all of the experiences that they have because they're babies. By preschool age, so once kids start spending more time in groups of their peers, this is around the age when peers too start to enforce gender norms. So that gender nonconforming kid who wants to be the dad in role play games, her peers might tell her, no, you can't be, you're a girl, so you have to be the mom. Okay, so this video kind of illustrates how gender roles are imposed on babies.
Sophie. Look, what does this say? Sweet dreams. Sweet dreams. Ooh, look at this, Sophie. Meow, meow. I think she liked that pink dummy the best.
If I were to tell you actually that Sophie is Edward,
Ah,
does that change anything?
I maybe thought, oh, this is a little girl, so I have to give her little girl things.
Hello. 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 Hello.
What's this? Oh, what's that one? Is that a robot? What about this? Oh, you like that one? What does this one do? Oliver. Oliver.
You've gone for, you could say boy toys.
Possibly my subconscious, but for me, I was just going for what was around me, but the impact of my subconscious was automatically playing a trick on me that I was
If I tell you that he is actually a girl.
really?
Yes.
Oh wow, that's really interesting. I suppose it's because of the stereotype.
And then that changed your behaviour
Yes,
towards
it
the
did.
child.
It did.
And your
I
behaviour
can't
was
lie,
quite
it did.
directed.
2, 3. Beep, 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 beep. Can I see my robot?
Go. Ask me. And it's just physical having a child. What's happening?
That really astounded me because I thought that I was somebody that had a really open mind.
Surprised. They all automatically make me fluffy toys to see the girl, so nice stereotyping.
I've always thought I was rather more open-minded than that. I would think, it's children's toys, not have an agenda.
It will make me think the next time I'm with a child, so maybe I use my nephew to make sure that I am actually being sort of fair and equal with all of them, and just giving each child an opportunity to just be whoever they are.
Okay. So what that video is illustrating is that adults have expectations about what kinds of toys children would want to play with based on their gender. This isn't like completely divorced from reality. There are apparent gender differences in the toy preferences that babies that age, the age of the kids in the videos, already have by 9 months. So boys are more likely to want to play with like trucks and cars and things like weapons and balls, so like physical spatial toys. And girls are already showing a preference towards playing with dolls at that age. There's also some gender differences in preschool age kids in the themes of their role play. So preschool age girls are more likely to play like family-based games, and boys are more likely to enact war and sort of violent themes in their play. But in infants and in preschoolers, there are still way more similarities than differences in play. So boys and girls are equally likely to role play as like animals, superheroes. They like to play with Legos. They all play with art supplies. So what this is showing is that there really are gender differences, but it's basically impossible to divorce the gender differences that are already apparent at 9 months from the fact that from birth to 9 months old, those children are already being treated differently because of the assumption that they were a boy or a girl. And that video shows how this happens. Adults, without really meaning to direct boys towards what adults consider to be boy toys and girls towards what adults consider to be girl toys. So adults typically don't go out of their way to intentionally punish kids for showing an interest in sort of gender non-conforming toys, but they do things like you saw in the video, like redirecting, giving them more attention when they're playing with the right toys, and initiating the kind of play that the adult thinks is convergent with the child's gender. There is a lot of evidence that adults will talk more to girls, they'll read to them more, they'll engage in more conversations about emotions, and they'll help them label their feelings more. And with boys, adults are more likely to give them opportunities to walk around independently, to play with toys that help them learn spatial awareness, and manipulate objects. So these differences in how adults kind of subconsciously treat boy and girl children helps to set up some of the real gender differences that we see later in life, where it's true that boys and men are more likely to go into careers that involve spatial reasoning skills, and girls and women are more likely to have bigger vocabularies and more emotional maturity at an early age. It's not necessarily because these are inherent differences between men and women, it's just how men and women have been conditioned from the time that they were infants. So you could ask, if we treated all infants the same, if we didn't assign, if we like really were able to not put any gender roles on them, or if in a really unethical experiment, we took a baby who appeared to be a boy who had male like sex characteristics and raised him as a girl, would he grow up to be a girl and have gender confirming play and interests? So that experiment would be horribly unethical, but actually somebody did it. So that's what this study was about.
Bruce Reimer was a boy born in Winnipeg, Canada, alongside his twin brother Brian, August 22nd, 1965. As the twins started growing, they showed some problems urinating due to phimosis, a condition in which foreskin cannot be pulled back off the head of the penis. When the boys were 7 months old, their parents Janet and Ronald Reimer took them to get circumcised in order to fix the problem. What the parents didn't know was that the doctor in charge of the circumcision was using a method of cauterization, a burning technique, instead of a traditional blade. During the procedure, Bruce Reimer suffered a horrible accident that resulted in his penis being burnt off. His parents were devastated by this, and after hearing of their son's accident, they decided against having his brother Brian circumcised, whose phimosis later cleared on its own. While questioning whether or not their son would be happy as a male with no penis, their mother happened to be watching a show on television that featured a psychologist named Dr. John Money, who specialized in biology of gender and sexual identity. He appeared charismatic, intelligent, and confident, and he was also well respected and reputable in his field by his peers. He had a theory that gender was not something you were born into, but something learned through socialization and upbringing. The parents felt this was the answer to their son's problem, so they contacted Dr. Money and told him of their situation. Dr. Money invited them to Johns Hopkins Hospital in Baltimore to meet with him. After discussing the matter, the doctor convinced the parents that it would be in their son's best interest to raise him as a girl. So it began. And while his brother Brian was raised like a boy, Bruce was raised as a girl and was given the new name Brenda. At 22 months old, his testicles were removed. He was given dolls and other girlish toys to play with, pretty dresses to wear, and as instructed, they did not tell Brenda about his accident. He and his brother would both go to yearly appointments to see Dr. Money so he could keep watch on Brenda's progress. It's worth mentioning that the twins were a perfect experiment for him to test his nurtured, not natured theory, given the circumstance that there were 2 of them from the same genes for him to compare to each other. However, some issues arose. His parents and the doctor could see that he was showing more masculinity than he was feminine qualities. His brother Brian would share his toys with Brenda because Brenda was happier playing with things boys played with, and playing games that boys normally played. Brenda showed no sign of feeling like a female. If Brenda didn't fully accept being female as his identity, it would disprove Dr. Money's theory and his book about gender being a result of social construction. At 7 years old, boys started to be subjected to more sexualized experiments, like being asked what the differences are between boys and girls, and taught the sexual roles played by men and women. The doctor would make them role play the positions themselves, like Brian standing behind Brenda and leaning his crotch against his brother's behind. He would also force the boys to inspect each other's genitals. On one occasion, he had the children undressed and took photographs of them. If the children did not do as asked, the doctor would yell at them, to the point where they thought they would be struck. The children did not like the sessions with the doctor, but they didn't tell their parents what was going on. It was also around this age. Dr. Money tried talking Brenda into going through an operation that would completely change his parts to what he told Brenda they were supposed to look like a girl. Brenda was very scared of the thought and refused. Later on, when Brenda was becoming a teenager, the doctor made one last attempt to convince him about the operation. He invited another patient of his, a transgender female who had undergone an operation willingly, to talk with Brenda. It was after this that Brenda told his parents that he would kill himself if he had to see the doctor again. It was at this time the parents felt it was best to tell their sons the truth. Ron took Brenda out for ice cream, while Janet took Brian elsewhere so they could individually tell their sons the truth, that Brenda was actually born a boy. Brenda, after being told that he was actually born a male, felt immense relief. He felt like himself and he was happy. His brother, however, could not handle the situation and took great shock to the news that his sister was actually his brother. The events surrounding Brenda caused a mental disturbance in Brian Reimer that would eventually lead to schizophrenia and his detachment from his brother. Brenda was ready to take on his new life and renamed himself David. Before he was excluded by the kids in school for his differences, teased and tormented, and felt different from everyone. Now he started making friends, had positive thoughts about the future, and embraced his identity as a boy. He started taking testosterone supplements to counteract the effects of estrogen hormones that the doctor had given to him over the years. This led to him getting a double mastectomy to remove his hormone-induced female breasts and 2 phalloplasty operations to recreate his penis. He also received a sum of money for the botched circumcision. Eventually, David met a woman named Jane Fontaine who had 3 children. They fell in love, got married, and David was happy with his new life. Things seemed to be looking upward. However, things changed when David heard that Dr. Money was informing people that his experiment with David wanting to be a girl was a success, and nothing could be further from the truth. This caused David to get a hold of his brother so they could speak out against the doctor in the hopes of keeping other children from having to go through what he did. Brian agreed, and they opened up to the world about the truth of their history with Dr. Money. Later, in 2002, Brian Reimer was found dead after overdosing on antidepressants. Aside from David having to deal with his brother's death, he was conned out of $65,000 in a bad deal and was having trouble finding work. He was also having problems with his marriage, in which his wife asked for separation time. On May 2nd, 2004, David sawed off the end of a shotgun and drove to a nearby grocery store where he shot himself in the head. He was 38 years old when he took his life.
Okay. So just a note that as you talked about, schizophrenia is a very strongly heritable, genetically mediated disease, and it's not caused by negative life events like this. It's not caused by being shocked that your sibling has a different gender identity than you thought they had. It's also not caused by sexual abuse, even though they did both experience that. Okay, so is gender just a social construct? That's what John Money thought, but he was definitely super wrong. There is really solid evidence that by age 3 to 4, most children have an innate sense that they are a boy or a girl. And we know that this isn't a product of society because it's true even in children who have a pretty gender nonconforming or gender neutral upbringing. It's true in societies that are very egalitarian, where adults might treat boys and girls a little bit more equally, and where adult men and women have more equal rights. And gender identity is very strongly related to biological sex. Biological sex is just the strongest predictor of gender identity. However, gender expression and the way that cis men and cis women express their masculinity and femininity, as well as the way that trans men and women express their masculinity and femininity, is a social construct, and it's very strongly influenced by gender norms and gender roles. So wearing a dress isn't something that women have an innate desire to do. It's not part of feeling like a woman. It's just what women do in our society. And when you feel like a woman, it's reinforcing to do the things that women do. Okay, so gender identity is a developmental process. By the time kids are about 2 years old, they show an awareness that boys and girls are different. By age 3, they start to consistently identify themselves as a boy or a girl. And by age 4, they have developed a pretty consistent gender identity. So by age 4, at least most cis kids know that they are a boy or a girl. Gender identity development might not be that linear for trans kids because they're getting such conflicting messages from their internal sense of what their gender is and from society and what their parents are saying through no fault of their parents, because again, gender is strongly related to biological sex. Okay, so I mentioned the little sexual behavior orientation, romantic love, and sexual attraction spectrum I showed earlier was not really inclusive enough. So the gender unicorn is a way of expressing gender identity, gender expression, and sexual orientation that was developed by trans people and trans self-advocates. So the idea is that it's not that masculinity and femininity, or being a woman or being a man, are on opposite ends of the same spectrum. They're actually each on their own spectrum, where you can be not at all like a woman or a lot like a woman. But the same person can also be anywhere from not at all like a man to a lot like a man. And also that person can vary in the degree to which they are androgynous or not a man or a woman. The same goes for gender expression. So again, it's important to remember that masculinity and femininity aren't opposite ends of the same spectrum. They're two completely different spectra, and all of us are on both of them to different degrees. So in addition to masculinity and femininity, maleness and femaleness, there's also the concept of a non-binary gender. So this figure is a little bit complicated, but this is from a really big survey of gender diverse adults. So it included cis men, cis women, trans men, and trans women, and also agender people who were assigned male or female at birth. So what this is showing is that so blue circles are trans women, so people who were assigned male at birth, but who identify as women. In the blue circles are people who were assigned male at birth and identify as men. So red circles are trans women, blue circles are cis men. Green circles are people who were assigned male at birth, but who have a non-binary gender identity. And what this is showing is that most trans women strongly feel like women and don't really feel that much like men. Most cis men really feel like men and don't really feel that much like women. Although there are plenty of individuals who are somewhere in the middle of both of these gender spectra, regardless of their gender identity. However, the majority of female-identified AMAB people feel like women, and the majority of male-identified AMAB people feel like men. Non-binary people are those who really feel like both, who don't strongly cluster on the extreme of either gender spectrum. The same is true of cis women, so AFAB people who are cis, and AFAB people who are men, so trans men. Similarly, both trans men and trans women, cis men, trans women, cis women, trans men, tend to say that they don't really feel like both genders. They feel like a gender, whereas non-binary people are more likely to say that they feel like both genders. These statements are kind of long, and they're similar, although they're from two different Reddit commenters. So I'm just going to read the second one. They were just answering a question about what it feels like to have gender dysphoria and be non-binary. So this person says, in my case, being non-binary means to me that I struggle to associate myself with either male or female. It's a bit deeper than me just wanting an alibi to wear this or that outfit. I've got some sort of body dysphoria, and if I had the choice, you can bet that I would make changes to make my body look more neutral. It has to do with how I perceive myself and how I want others to perceive and interact with me. I just want to look at myself in the mirror and feel good about myself. I want to be able to wear clothes and do things in a way that doesn't make me feel self-conscious. And I want people to not interact with me in a way that ever has to do with them pointing out my sex or gender to me, as if it had any relevance to the conversation. So for most of us who have a binary gender identity, whether that's male or female, we want people who are interacting with us to interact with us as the gender that we identify with. That's not true for non-binary people, for the most part. Just going to play a few minutes of this video. This YouTube video was made by a YouTuber with the explicit purpose of actually showcasing like older adults, so people in their mid to late 20s through 70s who are non-binary, because there is kind of a misperception that non-binary gender identity is like a phenomenon or a phase or a fad for young people, and that's not true. Non-binary genders have always existed.
I formally realized that I was non-binary approximately 3 years ago.
I realized that I was not binary pretty much my whole life, but I just didn't have language for it until I was in my mid-20s.
However, I have felt agender as a young child. I just didn't have the words for it.
I was wearing makeup, having facial hair, expressing my gender in lots of different ways, years and years and years. Now, 7 years ago, I started posting online and younger people started writing into me saying, oh, what are your pronouns? How do you identify? Are you genderqueer? And I remember really.
I realized I was non-binary pretty early on, I guess, in my teens. Back then, we didn't really have the word non-binary. At the time, the word that was popular was genderqueer.
I stumbled across the word genderqueer in 2012 on the internet. At that time, I was 26 and immediately adopted it for myself because it felt like the final piece to a puzzle that I've been looking for my entire life in regards to my gender. It was a couple of years after that I saw people increasingly using the term non-binary, and eventually I started identifying as non-binary, born and genderqueer.
Even back then, I had very typical dysphoric days. I would like put on clothes that I was wearing the day before, like a dress, and then I would look in the mirror and be like, looking at somebody that wasn't myself. It was really, really distressing. And I just started to notice different things about myself that were starting to feel more and more uncomfortable when it came to being seen as a woman.
All my life, I knew I wasn't a boy. I knew I wasn't a man. And so all my life, I had to pretend to be a boy or a man. It's very conscious pretend. Finally, I decided to go through with what we call the sex change. And I went through it, woke up off the surgeon's table, and my golly, I was a woman. And I was so happy with that.
It took a couple of years, even just to get to the point where I knew that I was non-binary. And then it was only within the last year that I finally had chest reduction surgery and I started using they, them pronouns. So 4 years, and this started when I was 40 years old.
And then for the next 4 or 5 months, I was going, okay, how do you be a woman? And I pretended to be a woman. Realized I had no idea about being a woman any more than I had an idea about being a man.
I don't know why there's this idea that all non-binary people are super young and in their teens to the early 20s, but I think that has something to do with it being a new term. I think that maybe it's related to language. There was a nautical language and discourse around gender diversity until quite recently, at least on this level.
Okay, so this figure is from the same research study that the last figure was from, but this is basically just showing scores on a measure of non-binary gender identity. So how strongly do you identify with a non-binary gender? How strongly do you feel that you are neither a man nor a woman? Cis men, cis women, trans women, and trans men all scored really low on this, although again, you can see that gender is a spectrum for everyone. Even people who have a binary gender identity sometimes do have feelings of being neither gender or being some middle gender. But people who have a non-binary gender identity feel this way much more strongly. Okay, so we've been kind of talking about the difference between biological sex and gender for a little while, but just a quick primer on what actually influences the development of biological sex and where our gender assignments typically come from. So there are actually 5 separate factors that influence the development of biological sex. Most cis people have all 5 in congruence with each other, but people who have one or more of the 5 kind of pointing in different directions, either towards opposite biological sexes or towards an ambiguous middle sex. Those are people who have a disorder of sexual development or an intersex condition. Disorder of sexual development is the more modern term than intersex. Okay, so the first factor that influences the development of biological sex is our chromosomes. This is also known as a karyotype. So we all know this, but most people have either XY chromosomes or XX chromosomes. And if you have XX chromosomes, you're probably biologically female. And if you have XY chromosomes, you're probably biologically male. Another factor that influences development of biological sex is our gonads, whether we have testes outside of our body or ovaries inside of our body. And gonads are important during puberty because when we go through puberty, our gonads begin producing sex-congruent hormones that flood our bodies with either masculinizing or feminizing hormones during puberty. And that's what causes us to develop secondary sex characteristics. So hormones are important during puberty, but they're also important, as we talked about, during adrenarche. So when our adrenal glands are maturing and starting to produce androgens, this is the beginning of sexual and romantic desire and sexual behavior orientation. But that's not the only time that we're exposed to hormones. We're also exposed to hormones in utero. We're exposed to hormones during adrenarche, and we're exposed to hormones during puberty and then throughout our lives. And it's not just what hormones our body is producing, it's also what hormone receptors are available on our cells. So everyone's body produces androgens, everyone's body produces testosterone, but women have far fewer testosterone receptors. So the testosterone that's floating around in the body of a cis woman isn't binding to a receptor, and therefore it's not having an effect on her development or on her behavior. Another factor is our internal reproductive structures. So if for most cis women, we have a cervix and a uterus, for most men, they don't have those structures. And then lastly, our external genitalia help to identify which biological sex we are. But actually, unlike our hormones, gonads, and chromosomes, our genitals don't actually do anything to influence our development, at least not our physical development. Our genitals are basically just a byproduct of all of these other things. But guess what? Genitals are the only factor that's usually used to assign a biological sex at birth. And usually that's not super problematic because for most people, our genitals are a good indicator of what these other 4 factors are. And it wouldn't make sense to give babies like abdominal ultrasounds to see if they have ovaries and a uterus at birth if they don't have ambiguous genitals, for the most part. Although there are plenty of people with disorders of sexual development who don't have ambiguous genitals, but have other factors that influence their development differently. Okay. Oops. So this should have said intersex conditions, also known as disorders of sexual development. They're pretty common. As far as we know, the prevalence is about 0.2 to 1% of live births, but it actually could be higher because, again, oftentimes these diagnoses are made based on ambiguous genitalia, and that's only one of the 5 factors that can influence whether someone has a disorder of sexual development or is intersex. Intersex is an identity that some people have. So people who identify as intersex don't consider it a disorder or a condition. They just are intersex, but the clinical term is disorder of sexual development. Okay, so one example of a disorder of sexual development where the karyotype is incongruous with other aspects of someone's someone's apparent biological sex is complete androgen insensitivity. So this is a disorder of sexual development that affects people with an XY karyotype. And usually those people are male. However, these people with complete androgen insensitivity, have a genetic mutation that leads to their cells having 0 working testosterone receptors. So even though their body is producing androgens during adrenarche, they're producing a lot of testosterone. During puberty, their body's flooded with gonadal androgens and testosterone. All this testosterone in their body has no influence on their physical development because it's not binding to a receptor. It's not doing what it is supposed to do to masculinize the body and to create male patterns of sexual desire and behavior and male secondary sex characteristics. It also doesn't have the masculinizing effect on their external genitalia while they're in utero. So they're born with vaginas and they look biologically female. They develop as girls. They go through female puberty because they have normal estrogen production. And they never develop male secondary sex characteristics. They develop breasts and other signs of being female, but they don't have periods. And when they go to the doctor to figure out why, it turns out that they don't have ovaries or a uterus. They have testes inside their body. They are quote unquote biologically male based on their chromosomes, as well as based on the gonads and reproductive organs they have. But they look like women and they feel like women. Complete androgen insensitivity is not associated with gender dysphoria. Women with this condition people with this condition have the same prevalence of gender dysphoria as the general population. They are as likely as people with XX chromosomes to identify as women. I'm going to skip this for the time being, but if you're curious, this video is a person's experience of being diagnosed with complete androgen insensitivity. And like many people, she had no idea until she was already through puberty and was going to the doctor to try to understand why she wasn't menstruating. Okay. Another disorder of sexual development that also happens at the level of karyotype, at the level of chromosomes, is a trisomy condition, which means that someone has 3 copies of one set of chromosomes when they should only have 2. And this is trisomy of the sex chromosomes, where infants are born with 2 X chromosomes, which normally would make them girls, but they also have a Y chromosome, which masculinizes their body. So the Y chromosome causes their genitals to develop as masculine, as well as their internal organs and their gonads. But the two X hormones cause their testosterone production and testosterone receptor availability to be lower. So they tend to be born with more ambiguous genitalia, as well as during puberty develop ambiguous secondary sex characteristics. They have more breast tissue and less body hair than most XY men. People with Klinefelter syndrome tend to identify as men, but there is a higher prevalence of gender dysphoria in people with Klinefelter's syndrome than the general population. So they tend to be assigned male at birth, and in adolescence or childhood through adolescence, they're more likely to identify as women. There's a little bit less understanding of gender dysphoria in Klinefelter syndrome because it, in addition to affecting sexual development, it's also associated with other developmental abnormalities, which complete androgen insensitivity is not, and neither is the next disorder of sexual development we're going to talk about. But people with Klinefelter syndrome tend to have a low IQ. And if you watch the optional video this week, the guest speaker talks a little bit about why consent is required for transgender care. So someone with low IQ who can't consent on their own to gender confirming treatment might never get the diagnosis of gender dysphoria. Okay, so the last disorder of sexual development I'm going to talk about is congenital adrenal hyperplasia. So remember that the adrenal glands secrete testosterone and androgens in the body. So these are people who have two X chromosomes, which usually would make them develop as girls. But from the time that they're in utero, the egg and the fetus is exposed to extra testosterone. So they're born with slightly masculinized genitals. The degree to which the genitals are masculinized, it depends on how much testosterone they were exposed to. And what I mean by masculinized genitals is that they have vaginas, but they also have enlarged clitorises. In some cases, people with congenital adrenal hyperplasia will also develop some male secondary sex characteristics at puberty. So they might have body hair and facial hair, and they might have a more like masculine body shape, as well as like a sort of masculine fat distribution where they tend to acquire fat around the abdomen and less in like an hourglass way. In childhood, people who are identified as girls with CAH tend to be more gender nonconforming than other girls, including than their own like sisters who don't have congenital adrenal hyperplasia. So there is something to be said for the relationship between testosterone exposure and gender conformity. So these girls tend to be seen as a little bit more masculine. They also do have a higher prevalence of gender dysphoria. Oops. The prevalence ranges from 5 to 12% in this population, which is much higher than the prevalence of gender dysphoria in the general population. But as I'll talk about in a later slide, the prevalence of gender dysphoria actually depends on the sex that they're assigned at birth. So some people with CAH are born with such masculinized genitals that, according to the way that we used to address disorders of sexual development, they were actually assigned male and raised as boys. So CAH girls who are raised as boys are way more likely to have gender dysphoria about their male gender identity and feel like women than CAH girls who are raised as women are to feel like men, 5% versus 12%. So the cases of congenital adrenal hyperplasia and complete androgen insensitivity really help to illustrate how complicated sex is and its relationship to gender. So there is some research that suggests that in people who are identified as trans, the degree to which their appearance, so their like facial features and their secondary sex characteristics and genitals matches their gender identity is associated with less dysphoria. We also know that hormone exposure is one of the 5 drivers of biological sex. So in congenital adrenal hyperplasia, there's a lot of androgen exposure, which predisposes people towards more masculinized patterns of behavior. And it also creates some masculine features, which could lead the world and peers and society to treat you more like a man and to expect you to engage in more masculine play and behavior. On the other hand, women with complete androgen insensitivity actually often tend to be really feminine and not really have any kind of masculine features or behaviors because they're not exposed to any androgens and because from birth they again look really feminine and so are really treated like girls. So socialization could be a difference. And another important difference is that complete androgen sensitivity is invisible and it's not diagnosed at birth, whereas CAH usually is diagnosed at birth. So these are children who are raised with the knowledge that they have a disorder of sexual development, and that does influence socialization. But like I said, most people with CAH, congenital adrenal hyperplasia, are women, are girls. So despite having really masculinized genitals and being assigned male based on their genitals, that's often a mistake. They are way more likely to have gender dysphoria than the general population, and compared to CAH girls who are assigned female. Okay, so I wanted to just like incorporate a little bit of trans history into this lecture. So this is an example of someone who may have had an intersex condition, a disordered sexual development, and potentially a transgender identity. So the Chevalier d'Eon was like a nobleman who lived as a man until he was almost 50, and he was a military officer. Even then, as he was like identified as a man and living as a man, he was known for being kind of gender nonconforming, to the extent that a lot of people gendered him as a man, as a woman, thought that he was a woman passing as a man. So his gender presentation was a little confusing for his peers. Later in life, after their military career was over, they actually started to claim that they were born female, but that they were raised as a boy so that their family could have a male heir. And because their gender presentation was so feminine and their gender identity was so confusing and upsetting to people, the king actually ordered them to live as a woman, which by all accounts, she was happy to do. And she lived the rest of her life as a woman. When she died, it turned out that she had ambiguous genitalia and secondary sexual characteristics associated with both genders. So she may have had an intersex condition. But this is an example of a historical figure who probably was trans, although we can't put that label on people who didn't have that understanding of their own gender. Okay, so a little note about trans mental health. Unlike paraphilias, which are associated more with positive affect and enjoyment and a positive sense of identity, gender dysphoria is kind of distressing by definition. That's what dysphoria means. It means being unhappy, upset about your gender presentation and your gender roles. And young people, especially adolescents and adults, but in some studies, even children with gender dysphoria have high rates of anxiety and depression. Gender dysphoria is also related to things like substance abuse, self-harm, and suicidality. So kind of these might be seen as really unhealthy ways of coping with the intense dysphoria and distress that many trans people experience before transition. So how do we treat gender dysphoria? The best treatment for gender dysphoria is to live in accordance with your gender identity. Transition, so the process of shifting your gender expression and gender identity from the one you were assigned at birth to the one that you identify with internally, is known as transition. And it's known to improve mental health and to prevent suicide in trans people. We know this because the later someone transitions in life, so the more exposure they had over their lives to gender dysphoria, the higher rates of psychopathology they have compared to their cis peers. When trans children have their identity affirmed early, like as soon as they start expressing it, they grow up with the same rates of psychopathology as their peers. So being trans in and of itself is not pathological if you're able to live in congruence with your identity. Similar to being gay, lesbian, or bi, it's not that being trans itself is pathological, it's being trans in a society that doesn't accept being trans and forces you to live a life that causes you gender dysphoria. The strongest predictor of positive mental health outcomes in trans adults is the extent to which they've transitioned and the extent to which they're open and not closeted about their gender identity. So trans adults who have fully transitioned, whatever that means to them, have better mental health outcomes than trans adults who are, for whatever reason, not able to transition or who are still closeted and living as their assigned gender. Studies also suggest that when trans people are denied gender confirming treatment, their risk of suicide increases. So transition is kind of a complicated concept, and this is actually the focus of the guest lecture conversation with Claire Roden, who is an adolescent medicine physician who's an expert on transgender care. But transition basically includes kind of three themes: social transition, hormonal transition, and surgical transition. Social transition is about how you present yourself to the world and what you want people to call you and how you want people to relate to you. So it's the pronouns you use, the way that you dress, the behavior that you engage in, whether that's concordant with female gender roles, male gender roles, or whether that behavior is non-binary. Hormonal transition also kind of has two parts. So when someone is beginning puberty, they can be treated with hormone blockers, which prevent them from completing what's known as their natal puberty, or the natural development that they would go through where their gonads, whether those are ovaries or testosterone, would produce hormones that would influence their development of secondary sex characteristics. So if someone is assigned female at birth and is allowed to go through puberty, they, as a woman, they will develop like softer facial features, less of a brow ridge. They won't develop an Adam's apple. They'll develop like an hourglass figure. They'll develop breasts. They won't develop body hair. If someone who's assigned male at birth goes through puberty as a man, they will develop body hair. It will change the texture and color of their genitals. They'll develop more masculinized facial features. They'll grow like a beard, body hair. So for children who are trans and who are entering puberty, the treatment of choice right now is puberty blockers, hormone blockers. These basically allow trans kids more time to explore their gender identity and socially transition without their body being exposed to hormones for the wrong sex. At this stage, if children decide that their gender actually is more congruent with the gender that they were assigned at birth, the effects of hormone blockers are totally reversible for the most part. There are some potential side effects with like bone mineral density acquisition, but the effects on appearance and secondary sex characteristics are reversible. Gender-affirming hormone therapy is used after someone has gone through natal puberty or after natal puberty has been suspended. Gender-affirming hormone therapy basically induces puberty of the sex that you were not assigned at birth. So the puberty of the hormonal sex that matches your gender identity. For people who are AFAB, so if I'm assigned female at birth, gender-affirming hormone therapy usually involves testosterone to some degree, and also often drugs to stop menstruation, because menstruation can cause a lot of dysphoria for men who menstruate. People who are assigned male at birth go through feminizing gender-affirming hormone therapy, typically involving really high doses of estrogen, also drugs that antagonize testosterone receptors, so anti-androgens, and also sometimes they stay on puberty blockers because those prevent their gonads from producing masculinizing hormones. Not everyone who's trans goes through all of these stages of transition, and as our guest speaker emphasized, transgender care is really about asking the person what type of intervention, what type of transition would relieve your dysphoria. If your dysphoria is mostly social and it comes from just being treated and related to as the wrong gender, maybe social transition is all you need to live in accordance with your gender. For many people, though, the physical body looking like the opposite gender, the gender that you're not, causes a lot of dysphoria. So a majority of trans people who get adequate care go through hormonal transition. Not everyone goes through surgical transition, which can include top surgery, so chest reduction, bottom surgery, so vaginoplasty, or using the skin from the penis to create a vagina, or phalloplasty, which is using the skin from the vagina to create a penis. Some trans women also go through facial feminization surgery, which helps to reduce and undo some of the masculinizing effects of male puberty on their face. That type of surgery may not be necessary for kids whose transition starts before they've completely gone through their natal puberty. Okay, and it's, again, important to remember that not everyone has access to transition and not everyone wants to transition for whatever the reason. Whether or not someone has transitioned is not what makes a person trans. Having gender dysphoria is what makes someone trans. Okay, so the recommendation now is that because children know their gender identity, the average age for trans kids to know their gender identity is around age 7 to 8. the average age for them to disclose that used to be later in adolescence, like 16, 17. But with greater acceptance and visibility of trans people, it has gotten earlier. So now when children know that they're trans early in life, or when children are very gender nonconforming and expressing dysphoria and reluctance to go through puberty, the recommended transition sequence is first social transition. So when a child starts expressing that they are the wrong sex, that they were told that they were a girl, but they're actually a boy, social transition is the recommendation. So parents should encourage and allow their kids to use the pronouns that they identify with, to wear the clothes that match their gender identity, and to engage in the play behaviors and activities that they want to, which that last thing parents, hopefully do regardless of their child's gender identity. Basically, social transition should be child-led, and the child should just basically be allowed to live and behave as they feel comfortable. Often, as we'll talk about later, what is believed to be gender dysphoria in a child actually just turns out to be gender non-conforming behavior. And as puberty approaches, kids who are gender non-conforming often start to realize that regardless of how gender non-conforming they are, their gender identity is either the gender that they were assigned at birth or a trans identity. Puberty tends to really reveal whether or not someone has true lasting gender dysphoria and will go on to transition. So as puberty approaches, the child knows whether or not they are willing to go through that puberty, whether going through that puberty will cause them a lot of dysphoria, or whether they're ready and are ready to go through natal puberty. If they're not, as soon as puberty begins, but not before puberty begins, once puberty has started, then a child can go on hormone blockers if they want. And then typically around age 16 or by age 16, they can begin hormone replacement therapy. So they can go through gender confirming puberty. Typically, in the United States, it's not recommended that any child or adolescent go through surgical transition. That's something that they can decide to do as adults. However, hormonal transition, gender confirming hormone therapy in someone who is a natal female, taking testosterone will enlarge the clitoris, and in someone who's a natal male, taking estrogen will slightly shrink the penis, and it will also kind of feminize the body and cause them to grow breasts and not have as much body and facial hair. So hormone replacement therapy, gender confirming hormone therapy, tends to alleviate dysphoria around genitals and secondary sex characteristics. So we know that recognizing and confirming gender identity early in life prevents mental illness. When children are allowed to live in accordance with their feelings, the gender that they identify with, they experience less dysphoria, and dysphoria feels terrible. So children shouldn't be exposed to that if it can possibly be avoided. Also, getting to socially transition early when your peer group is younger and everyone's gender is a little bit less rigidly enforced sets kids up for less social rejection, and a better ability to integrate into the peer group that is appropriate for their gender identity. It's possible too that there are better outcomes if medical transition starts early. If someone goes through natal puberty, it can cause permanent changes to their body that, for example, in the case of trans women, sometimes they are exposed to so much testosterone during puberty that they are dysphoric about their facial features and go through facial feminization surgery. Hormone replacement therapy, blocking natal puberty and replacing natal puberty with gender confirming puberty can prevent that from happening. Okay, so another piece of trans history. Michael Dillon is one of the first people known to have actually medically transitioned using this sort of modern sequence of procedures. He was assigned female at birth, and he lived as a girl until he was in his 20s. He experienced really intense dysphoria, and from an early age, he felt like a man and expressed that to people around him. So in his 20s, he moved to Ireland, where he was prescribed hormone therapy. He legally transitioned, so he socially transitioned. He changed his legal identification. He changed his name, he changed his pronouns, and he underwent genital surgery. After surgery, he lived as a man. He had an average, well, kind of an extraordinary life because he ended up becoming a Buddhist monk, but he lived in accordance with his gender identity. And as far as we know, he was one of the first people to use hormone replacement therapy and bottom surgery to transition. So getting back to intersex conditions, I don't have a slide about this, but I really should emphasize that the majority of trans people are not intersex. Being intersex, having a disorder of sexual development, predisposes people to being transgender. It creates gender dysphoria for some people. But the majority of trans people are physiologically, quote unquote, normal. There's nothing biologically different about most trans people that we know. So even though biological sex is usually related to gender identity, it's really like the best predictor of what someone's gender identity will be. There are people whose biological sex, even though it's clearly masculine or clearly feminine, have a different gender identity, and it's not because of any known biological factors. So the way that intersex conditions used to be handled was a sex was assigned at birth based on the appearance of genitals. If the genitals were ambiguous, they would just choose a sex and do surgery to make the genitals look like that sex. That's what was done to David Reimer. Children like David were then raised as that assigned gender, and this disorder of sexual development was a secret that was kept from them. So we don't know this because there hasn't really been research on this population, but it almost definitely caused more gender dysphoria than it prevented. We do know from congenital adrenal hyperplasia that these are mostly biological females who just were exposed to a lot of testosterone. So they have XX chromosomes, they have ovaries, they have uteruses. They may or may not have ambiguous genitalia, but they do have vaginas and clitorises and vulvas, not penises and testicles. And they were just exposed to more masculinizing hormones than most girls are. So most of their sex characteristics point towards female sex. And in fact, they're less likely to have gender dysphoria if they're raised as girls than if they're raised as boys. And that's despite the fact that the reason someone with CAH would have been raised as a boy was that her clitoris really looked like a penis when she was born. So the way that disorders of sexual development are treated now is more of a wait and see approach. So if a child is born with ambiguous genitalia, more testing can be done. It's easier now to see like what karyotype they have. It's easy to do a scan and see if they have ovaries and uterus. So gender is still typically assigned to these kids that matches their internal organs and their chromosomes. But parents of kids like this should still wait and see what gender identity they start to express and be willing to go along with that gender identity and help them transition if needed. Before puberty, that's social transition. As puberty starts, it's deciding whether or not to block that puberty and prevent them from going through whatever puberty their hormones would expose them to. And then later deciding if they want to go through natal puberty later in life or go through hormone replacement puberty. But the important thing is that nobody should touch these kids' genitals until they are adults, and then they can decide if they want to have genital surgeries. Okay, so a controversial topic about trans medical care is this idea that, like, what if they regret transitioning? The fact that we treat gender dysphoria in young children, it kind of causes some people to make this like boogeyman argument, like, oh, doctors are operating on the genitals of 5-year-olds. Like, we're letting 5-year-olds make these life-changing decisions. It's not true. When a 5-year-old has gender dysphoria, the only transition is social. There's no medical intervention at all until a child enters puberty. So we're not even preventing them from entering puberty. They start puberty before any treatment happens. And that's really important because puberty really is kind of the tipping point where if someone is trans, it becomes very, very clear. Okay, so historically, the rates of regret in post-transition transgender adults have been really low. It's been like 1 to 7% who regret transitioning. And typically that almost invariably, that regret isn't like, oops, I actually am the gender that I was assigned at birth. That's uncommon. What was more common is that the regret came from the fact that like maybe the surgery caused pain or scarring, maybe they had bottom surgery and their genitals aren't as functional as they had hoped, or they might regret the decision to live openly as the gender that they identify with because it caused them to lose things that were important to them, like their relationship with their family, their role as like a husband, a wife, a father, or a mother. That change can be painful and that can cause regret. But generally the regret isn't that they got their gender identity wrong. People know what gender they are. So there are cohort effects to this too, and people who transition in the 21st century have much lower post-transition regret. And I think that this reflects both better transition care, so like the hormone therapy is more effective. We catch trans kids earlier and give them the treatment they need earlier, so fewer kids are going through puberty as the wrong sex. It also probably reflects greater acceptance of trans identities. So even though, as we'll talk about, trans people are still discriminated against, and it's still illegal to discriminate against trans people in many states in the US, there is greater visibility and greater acceptance of trans people now than there really ever has been in US history. Another boogeyman that has been raised that actually someone in one of my grad school classes tried to claim, so I researched it at the time and found that it wasn't true, is there's this idea that there's high rates of suicide in trans adults compared to cis adults, so compared to the general population. And this is adults who have transitioned. So between 0.5 and 2% of trans adults complete suicide. And that is higher than the general population. So his argument was that transition doesn't really help, that it's only like, I don't know. The argument was that transition doesn't help if trans adults still complete suicide at higher rates. But what studies have also found is that compared to trans adults who don't go through all the steps of transition that they want to, trans adults who are able to fully transition have lower rates of suicide. Or other studies have found that there just aren't like differences in the rate of suicide across stages of transition. So basically, there's definitely no evidence that transition increases risk for suicide. And if anything, it lowers the risk for suicide, which is admittedly higher in adults who are trans. It's not transition that contributes to suicidal feelings and behaviors. It's most likely dysphoria and the anxiety, depression, comorbidities that go along with dysphoria. So that was the statistics for trans adults, mostly people who transitioned in adulthood. The thing is, everyone transitions in adulthood, okay? We do not perform genital surgeries on children, including intersex children who have ambiguous genitals. That was a thing of the past, and really, like, at no time ever have we, as a field, consistently performed genital surgeries on children to change their gender expression. The criteria for gender dysphoria in kids include gender nonconforming behaviors that many kids who turn out to be cis engage in. Like, it's not uncommon for cis girls to prefer to play with boys, or for cis boys to prefer to play with girls. It's not at all uncommon for cis girls to not want to wear dresses and to prefer to wear boys' clothes. To be diagnosed with gender dysphoria, a child does have to demonstrate a lot of gender nonconforming behaviors, maybe more than the average cis kid would, but still, somewhere between 60 and 80% of kids who are quote unquote dysphoric in childhood, they actually weren't really dysphoric, they were just gender nonconforming. But 60 to 80% of them ultimately end up going through natal puberty and being cis. Studies that produce these numbers, like I said, they don't really do a good job of distinguishing between gender nonconformity and gender dysphoria. So, but also it can just be hard because often kids don't really feel the full weight of gender dysphoria until they approach puberty. The estimates of desisting, which is when an apparently gender dysphoric, but really gender nonconforming kid ends up being cis, those estimates are lower for kids who are in treatment at gender clinics, but that's just because of the population. A kid who's persistently gender dysphoric is more likely to end up in treatment sooner. And in fact, the predictors of persistent gender dysphoria, gender dysphoric disorder, and ultimately having a trans identity are when the dysphoria is insistent, persistent, and consistent. So a child who develops a gender identity that's not consistent with their biological sex assigned at birth, they know this to be true, nothing changes their mind about it, whether or not they articulate it to any adults, they know it internally. And it starts early and lasts a long time. More intense dysphoria in childhood predicts being trans, strength of identification with the non-natal gender. So someone who says, I am a boy, I just am, as opposed to someone who says, like, I want to be a boy, I wish I was a boy, it's more fun to play with boys. And gender dysphoria, when someone goes on to be trans, tends to intensify as puberty approaches, as gender identity remains stable. For kids who are gender nonconforming and maybe have aspects of a trans identity, so a child who maybe has socially transitioned, as puberty approaches, they might not experience that ramping up of gender dysphoria. And at the same time, as they enter natal puberty, those sex congruent hormones start to influence their gender identity and gender presentation. That's what happens with cis kids. What happens with trans kids is that as puberty approaches, their gender dysphoria gets worse. That's what was described by all those trans adults in that video. So age like 10 to 13, when puberty starts for most kids, is the critical age for persistence of gender dysphoria and the development of an adolescent or adult trans identity, or desistance and development of an adolescent or adult cis identity. Okay, we're almost done. So post-transition, trans people still often have a lot of mental health needs, and that's because problems like anxiety, depression, one that I didn't mention is eating disorders. People who have a lot of body dysphoria might do things like restrict their food intake to try to prevent menstruation, something that happens when you starve yourself is that you lose your period. Being really, really thin can also make someone look more androgynous or sort of interfere with the appearance of female secondary sex characteristics. Because when you're, a lot of female secondary sex characteristics have to do with fat placement on the body. So if you're in a state of starvation, you don't have body fat. So eating disorders are pretty common in the trans population, as are anxiety and depression. So problems that started with dysphoria sometimes are improved or resolved by transition, but not always. Sometimes a problem that started with dysphoria ends up being maintained by something else. Unfortunately, some trans people are born into families that aren't accepting. So for some trans people, they have to make the choice to go on with their transition and leave their family behind. And that is a difficult decision that requires mental health support. Many trans people do experience some residual dysphoria, either because they feel like they don't pass as fully as they want to. They feel like they still aren't seen by society as the man or the woman that they are. Or they might have body dysmorphia, which is where their perception of their body isn't realistic. It's not what other people see. Some trans people will say that it just took a while for their internal representation of their own body to catch up with what their body looked like post-transition. And then again, even beyond family rejection, all trans people, almost all trans people, will have to cope with transphobia and discrimination in society. Whether or not they fully pass, they might not like personally be victimized by discrimination because they might not be seen as trans, but being aware of transphobia in society and seeing other trans people get discriminated against is still enough to cause minority stress. So in 2019, 80% of trans people who were polled in this big survey of LGBT Americans said that they don't feel fully accepted by society. The rates for like sexual minorities, LGBT people, were a lot lower than that. They were especially low for lesbians and bi women. So again, minority stress is really bad for physical and mental health. And as we talked about, poverty and economic instability is really bad for mental health. And the fact that trans people don't have protection from job discrimination, you can still be fired for being trans in many states, including Alabama, or housing discrimination. A landlord can deny you a place to live because you're trans. Again, that happens here. So minority stress. Also, when it comes to trans identities, there are important intersections of race and gender and transition status. So of all trans identified people in America, Black trans women are at the highest risk for sexual violence and for hate crimes. So when our patients have multiple marginalized identities, in addition to being trans, they require extra care and attention. Okay, so we are at the end here. So this lecture covered sexual dysfunction, paraphilic disorders, and gender dysphoria. And here are kind of the main takeaways that I hope I conveyed in all of this talking. So when it comes to sexual dysfunction, desire, arousal, and orgasm are complicated. They can be affected by mood, they can be affected by physical condition, and they can be affected by context. So isolated sexual dysfunction symptoms, having a hard time getting aroused, having a hard time getting an erection, coming faster than you wanted to, having a hard time coming, not really feeling in the mood for sex when you think that you should. These are pretty common experiences, and they don't have to be impairing. Sexual dysfunction disorders are only diagnosed when those symptoms are present almost all the time and when they interfere with both partnered sex and solo sex. However, isolated symptoms of sexual dysfunction can turn into prolonged sexual dysfunction when someone has a lot of negative thoughts and anxiety about those symptoms. So treatment for sexual dysfunction definitely focuses on a medical workup to make sure that someone doesn't have circulation issues, nerve damage, or excessive amounts of serotonin in their system. And then cognitive behavioral therapy, education about sex, expanding the horizons of what sexual activity is can do a lot to take away someone's performance anxiety, but also just directly intervening on someone's negative, catastrophic, pessimistic thoughts about their own sexual performance. Paraphilias, which other than pedophilia fall under the umbrella of kinks and sexual behavior orientation, are really common, and even according to DSM, they're not disordered unless they're enacted non-consensually or if they cause the person who has them distress. But any non-consensual sex or sexual behavior is rape or sexual assault. I don't consider that a mental illness. Doesn't belong in DSM. So in my opinion, really the only treatment for paraphilias other than pedophilia is acceptance and helping the person to incorporate that part of their identity into the rest of their identity and engage in the behavior that makes them feel sexually fulfilled in a safe and positive way. And then lastly, gender dysphoria is the experience of distress caused by a mismatch between someone's internal gender identity and their assigned or assumed sex and gender. And the treatment for this is patient-led transition, whether that's social, hormonal, or surgical, or all of the above. Really the best treatment for gender dysphoria is to confirm someone's internal sense of their own gender because people know what their gender is. Okay, there's some extra readings and that is the end.